So this morning, I'm not going to waste too much time. We're going to start because we have to be on time. Basically, our theme is on multiple drug-resistant organisms. I have arranged a panel of specialists. Some of them are going to be presenting with Zoom, and some of them are going to be live. The first speaker is actually on Zoom right now, and she's ready to start speaking from America. It's 3 a.m. in America, and we cannot wait. So, my own talk, I'm just going to forget about it for now, but I'm going to call Mrs. Lola Jegede to pray before we start. Lola, Mrs. Jegede, please come and pray for us before we start. Quickly.
Let us pray. In Jesus' name. Father, Lord, we bless your name. We thank you, Lord. We magnify your holy name. We bless you for who you are. We thank you, O Lord, for your glory and honor that is present in this place this morning. We magnify your holy name. We thank you for everyone that is present here this morning. We thank you, O Lord, for the visionary of this gathering, for Larry Olubowale. Father, we magnify your holy name. We commit him unto your hands. We pray that you continue to magnify yourself in his life. We pray that you continue to glorify yourself in his life. And also for him to glorify your holy name on earth. And that's exactly what he's doing. To minister to people, to minister to the health of the people. Lord God, we thank you for how far you have brought him with all this help that is rendering for the people of Nigeria, for the whole universe. Father, we thank you. King of glory, we thank you. We commit everything this morning unto your hands, from the opening prayer to the closing event of this program today. Father, we thank you and we commit everything unto your hands. We cannot take anything for granted. It is because you have orchestrated this. That is why it is possible. Father, we thank you. We magnify your holy name. We thank you and we commit every speaker this morning, online and in person here, unto your hand. Father, we pray for your wisdom for them, your divine wisdom, Lord King of glory. If we think we have wisdom of our own, we are lying. Father, we thank you because you are great, you are good, and you do everything well in your own time. King of glory, we pray for everyone that is still coming on their way. We pray that you quicken their steps for them to be here safe in the mighty name of Jesus. Those that are already in here, Father, we pray, we thank you for their lives, and we commit everything unto your hands. We pray and we cover ourselves with the blood of Jesus. Every event today, Lord God, Father, come and do what you alone can do. In the mighty name of Jesus, we have prayed with thanksgiving. Amen. Amen.
Thank you. Well, the main theme, like I said, if we're going to take away anything from this event, this talk, is to know that each and every one of us, as medical practitioners or personnel, have a lot to play in reducing this problem of drug resistance. So, like I said, I've assembled a lot of speakers, and some of the speakers are going to be on Zoom, and the first speaker is going to be on Zoom. Is Dr. Chinelo Animalo. He's a professor of infectious disease from the University of Tennessee and in Memphis. Our profile is on the brochure, so you can see that I don't need to read it to you. She's my sister. She's supported me very well. She's always looked forward to being part of this program. And I'm glad we're able to coordinate this year, that she can be one of us, at least by Zoom, to present to us. She's going to be giving us the foundation of what we're going to be talking today, and she's got a very good grasp of the material she's going to be presenting. Chinelo, are you there?
Yes, I am.
Thank you. Welcome. Look, you can see the room. This is your country, so don't be surprised. The room looks empty, It doesn't matter. It's being recorded, okay? It's going to be on YouTube, and people are going to be able to listen to you. All your slides, and they're in the brochure, okay? They're going to be able to follow you very well, okay? So, thank you very much for honoring us, and we're looking forward to a very good presentation. Thank you.
Thank you. Good morning, everyone. Thank you, Dr. Folarin, for having me join this initiative. It's something that's very dear to my heart as a practicing clinician of infectious disease. And part of the difficulties that we face from our everyday practice would be, management of patients with infections with multi-drug resistant organisms. So I do not have any financial disclosures at this time. The objectives would be to discuss the history of antibiotics and emergence of antibiotics resistance, as well as factors that are associated with the emergence of multi-drug resistant organisms in the modern day era. So, what I wanted to do was to kind of give everybody a brief background of antibiotics, how we got here, and the things involved. So, before we go into, everybody knows that Dr. Alexander Fleming, is considered as the grandfather of antibiotics. But prior to that, I kind of wanted to give us what it was like in the pre-antibiotics era. So, dating back to like 2500 BC, that was, times of ancient civilizations. There was use of antimicrobials, in the medical field. In those days, they were using like moldy bread, that's bread with mold, and put that on wounds, as also, put that in gynecologic, infections in an attempt to curb, infections, because they noticed at that time that mold kind of had the ability to cure infections. And so it brought us down to the area of 1877. And at that time was where the concept of antibiosis was discovered. There's a lot of echoing. Can people hear me well? All right. So around 1877 was when we had that concept of antibiotics, basically, and this was discovered by the famous guy, Pastor Louis Pasteur. And what happened was that it was just the concept of biological process where they noticed that one organism would inhibit the growth of another organism. And that kind of brought us to where we are in terms of discovery of antibiotics. Around 1900, there was search for antibiotics. And back in 1928 was when Sir Alexander Fleming, discovered penicillin. So this, and he discovered that in his lab, where he noticed that a petri dish that had contained staph aureus kind of was cleared by this particular mold that was called Penicillium. And what he did was to try to kind of work on this organism and see the properties it had, which led to the discovery of penicillin in 1928. And it wasn't up until around 1940s that penicillin became widely available, all over the world. And immediately this happened, there was resistance immediately to their antibiotics. So they noticed that a bacterial enzyme called penicillinase was identified, and this had carried with it resistant strains that made it impossible for penicillin to work in those patients that were noticed to have this strain. And if you go all the way back to, the discovery of streptomycin around the 1944 era, this was used to treat tuberculosis in that time. The moment that streptomycin became widely available for use in treating TB, they noticed resistance amongst patients that were also being, where this antibiotics was being used. So what you can see is that the issue of resistance has been there, present from the inception of antibiotics. And so as other antibiotics were discovered and introduced into clinical practice, they also noticed the same events. So over time of this antibiotics era, the number of identified resistance mechanisms also increased at an alarming rate. So since the discovery of penicillin, there have been many more classes of antibiotics that were discovered between 1950s and 70s. And this is kind of, called the golden ages, which I'll talk about in a second. And that was basically the times that where majority of the of antibiotics that's being used in medical field today was discovered. The newer classes would be the oxazolidons, which was discovered around the 2000s, and the commonest of these would be the linezolid, which is one of the medications that we use currently for treatment of MRSA infections. The other group is the lipoglycopeptides, discovered around 2003, which is the commonest one would be daptomycin, also we use for MRSA infections. So as exciting and as the discovery of these new classes of antibiotics, it does come with a price. And what is it? Emergence of resistance to these classes of antibiotics. So this concept of resistance has literally grown into this full epidemic, and more studies are showing resistance to virtually every single class of antibiotics that exist in clinical practice today. These bugs or this kind of resistance or organisms, we call the MDROs or multi-drug resistant organisms. And, to the common man in the street, they are known as superbugs. So this is a brief illustration of what the events in the age of antibiotics looks like. And so you have the dark ages, which is the pre-antibiotics era that we talked about. Something I wanted to mention here, the dark ages is also called the Semmelweis era. Semmelweis was a physician, basically like an OBGYN physician, who suggested that to be able to prevent sepsis in women who were giving birth, that people should wash their hands thoroughly. It's amazing because we are literally back to where we were in the pre-antibiotics eras. That's prior to the discovery of antibiotics, where now part of what we're doing to prevent the spread of these multi-drug resistant organisms will be hand hygiene. So the dark ages again, the pre-antibiotics era, and then we come into the primordial age, which would be right around the 1940s, when penicillin was discovered, and other antibiotics like the sulfonamides. From there, we come into the 1950s, the golden ages, which is where most of the antibiotics that we use today was discovered. And when you move away from the 1950s, the golden age, then you come into the area that's kind of considered the lean years, and that would expand from around the 1960s to almost 2000. And why this is significant is this is the range where all the, basically the classes of antibiotics kind of fall into. After this period, there was basically a halt in development of new classes of antibiotics. And what happened was that around we call it the genomic era, around the 1990s was when major pharmaceutical companies, put in, millions of dollars and billions of dollars to try to develop new antibiotics classes. However, this did not have a very good outcome, and they ended up abandoning and discontinued this discovery program. And we are back to the 2000s again, which is the disenchantment phase, or basically the pre-antibiotics or the dark eras, where we're back to hand hygiene and other clinical practices that was done prior to the discovery of antibiotics. Something I wanted to point out, in this diagram here was, when they established the FDA Office of the New Drugs, that's the federal the FDA, basically, and what it does, that was when we had the issue with thalidomide. Everybody remembers the thalidomide and the issues with severe malformation of babies in women that had received thalidomide. And so this office was set up to kind of monitor development of new antibiotics and their major side effects. So if you look at this diagram here, what we're looking, I'm gonna go back to, basically look towards the 2000s. You can see that like for Staph aureus, if you look at the upper part, the 2004, it shows immediate, resistance to daptomycin. Daptomycin was discovered in 2003. And if you look at, let's say, Klebsiella pneumoniae, when Avicars, that's ceftazidime avibactam, was discovered in 2015, and immediately they recorded the first cases of resistance to this organism from a Klebsiella pneumoniae species. And then we are all aware as ID physicians or most, microbiology or infectious disease doctors that we are dealing now with Candida aureus, which was discovered around 2016. However, if you look back on the left side of this diagram, you're going to see where amphotericin was discovered around 1959. And by 2016, we now have this organism that's literally resistant to amphotericin. Okay, so let's look at the factors that are associated with the emergence of multi-drug resistant organisms in modern day era. Excessive prescription of antibiotics has been identified this as the major etiology of emergence of these organisms. And this is basically through selective pressure by the injudicious use of these organisms. And you cannot talk about, emergence of these organisms without mentioning the excessive use of pesticides and antibiotics in the agricultural sector. We are all aware that, at least here in the United States, and I believe all over the world, that pesticides and antibiotics are just given to, livestock in order to prevent, basically to prevent them from having infections that would kill these things. And so this also has been a major, major concern, all over the world in the emergence of this organism, not just from the human perspective, but also from the animal and agricultural sector. So the mode of spread has been a major concern, and the commonest mode will, include the consumption of infected animal products, as well as spread from food items like vegetables and fruits. And for us in the healthcare industry, person-to-person contact would be a major thing that one of my colleagues, speakers, would expatiate on. So let's look at the use of antibiotics in agriculture and the risk to human health. Again, we know that agriculture is a major thing, and the suspected mechanisms is the direct infection with resistance bacteria from an animal source and breaches in the species barriers, as well as transmission of resistant genes from agriculture into human pathogens. So again, I had just mentioned excessive prescription of antibiotics has been identified as the major etiology of this emergence of these organisms. I live in Tennessee. I live in Memphis, Tennessee in the US, and we rank number 5 in the entire nation for the injudicious use of antibiotics prescription. In Nigeria and other parts of the world, other contributing factors would include healthcare, environmental factors such as lack of regulatory policies, and the role of antimicrobial, stewardship programs and infection prevention and control, and then lack of or availability of guidelines to assist physicians and other prescribers, and patient pressure. I talk about patient pressure because, as it is here in the US, I'm sure that's how it is also in Nigeria, where, parents bring in their kids, or, somebody comes to see you. And if you don't give them prescription for medication, especially antibiotics, they kind of feel that you have done absolutely nothing for them. So everybody feels better when they walk away with prescription for some antibiotics. And then also the limited knowledge about antibiotics, as well as incorrect dosing by physicians, as well as mid-levels and pharmacists. This is important because when we use a subminimal dose to treat certain types of infection, it would promptly result in resistance, development of resistance. So where does this prescribing trends lead us? Let's look at this. Creation of slippery monsters, we call them little monsters, and in the world they are known as superbugs or multi-drug resistant organisms. So what is superbugs? Again, it refers to microbes that have enhanced morbidity and mortality due to multiple mutations and gives them high level resistance to antibiotics. And we've seen this occur in literally every single class of antibiotics that exists at this time. So the most dangerous of these organisms have been found in the healthcare setting and is believed to be mainly from person-to-person contact. And they've been, conflicting studies about the role of healthcare workers in the transmission of these organisms. This is literally an entire lecture on its own, but so I'm gonna, leave it there. But In terms of healthcare associated infections, with MRSA, VRE, and these are organisms that you see mostly in the hospital setting. Of course, MRSA is also in the community, but I'm talking about the hospital or nosocomial MRSA. And there's been studies that shown that we as healthcare workers, including doctors, nurses, physical therapists, we tend to take this from one person, from one room to the other. All right, so let's look at the worst offenders in the acute care setting. Methicillin-resistant Staph aureus, MRSA. I'm sure for most clinicians here, this would be literally one of our worst nightmares. C. diff, Clostridium difficile infection, vancomycin-resistant enterococcus, that's the VRE, as well as carbapenem-resistant enterobacteriaceae, which is known as the CRE. And the most notorious mode of care of spread will be the healthcare workers. And you also have, like the VISA, the vancomycin intermediate Staph aureus, as well as the vancomycin resistant Staph aureus. These are something that is beginning to be literally one of our worst nightmares, again, in the clinical setting, when you have patients that come in with this and you have very minimal options in terms of selection or choice of antibiotics. And this here is a list of other organisms that's listed by the CDC, the Center for Disease Control in America, that are organisms that we need to be wary of, especially in the healthcare settings. You have the ESBL producing enterobacteriaceae. We talked about the VRE. Of course, you cannot talk about this and not mention the multi-drug resistant Pseudomonas, or the carbapenem resistant Acinetobacter baumannii, as well as other organisms here. So there've been instances of outbreaks of these organisms in some healthcare facilities as well as some communities. And you've also had some documented outbreaks of this infection through infected medical instruments. And this has brought, led to the question about the effectiveness of the currently used disinfecting and cleaning techniques in the healthcare setting. So we are all aware of the outbreak of carbapenemase resistant enterobacteriaceae, that's CRE, following exposures to duodenoscopes here in the United States. For lack of time, I would not delve into that. So what is causing this resistance? Like we've talked about, again, the overuse of antibiotics. So according to the CDC, more than 50% of antimicrobials, when we talk about antimicrobials, we're talking about antibiotics, antivirals, as well as antifungal medications that are prescribed in the United States were deemed unnecessary, especially in the outpatient and inpatient setting. They antimicrobials are basically the only medications where the use in one patient can compromise the efficacy in other patients. I tried to use this example of the use of metoprolol in Mr. Smith and Mrs. Smith versus the use of meropenem, which is one of our carbapenem antibiotics, right? So Mr. Smith was admitted in the hospital, with an intra-abdominal infection and had this had to be in the hospital for several weeks and, ended up with a CRE infection, carbapenem resistant enterobacter infection. And fast forward to 6 months later, Mrs. Smith was admitted in the hospital for cholecystectomy. And, this was complicated by some infection also. And then they found that when they cultured the abscess, the abscess, it was also going in CRE. This Mrs. Smith has never been in the hospital or admitted. So how did she get this infection? And that's usually through transmission, horizontal transfer of genes or plasmids, probably from her husband. So Dr. Spellberg is a well-known ID doctor in ASP, there's antimicrobial stewardship programs. And what he did here was to kind of look at, compare different disease entities. If you look on the left side, you're going to see CAP, that's community-acquired pneumonia. And what he did was to look at the randomized clinical trials, that would be on your right side, and where studies that had used a shorter duration of antibiotics versus longer duration of antibiotics to see what the outcome was. And basically what it showed that use or shorter duration of antibiotics was as good as longer duration. So if we are able to treat community-acquired pneumonia with antibiotics for 3 to 5 days, why give 5 to 14 days and causing resistance? So another thing, another thing we are seeing here would be longer duration, of course, of antibiotics leading to more resistance. And what you see here would be, I don't know if you guys can see this graph very well, but basically what this is showing is correlation between the duration of use of antibiotics and then the emergence of resistance to fluoroquinolones as well as carbapenems on the right side. So I don't know if you all are able to see this slide. So let's look at the worst resistance is caused by the class of antibiotics called the carbapenems, as well as the fluoroquinolones. We're talking about ciprofloxacin and levofloxacin as being the worst in this category. Let's look at the worst offenders for resistance here. Again, you're looking at in terms of development of vancomycin-resistant enterococcus, methicillin-resistant Staph aureus, extended spectrum beta-lactamase or ESBL organisms, as well as the CREs, the carbapenem-resistant enterobacteriaceae. And so what are the worst offenders? I'm talking about the classes of antibiotics, and what you're going to see here would be second and third generation cephalosporins, fluoroquinolones, as well as the carbapenems. So these are, for those in clinical practice, these are very common antibiotics that we literally use every single day. And for me, let's say if I have 20 patients I'm rounding on today, I know that more than half of my patients are going to be receiving one or two of these classes of antibiotics. So longer duration also leads to higher risk of C. diff infection. And what the study showed basically was that the longer we leave patients on antibiotics, less than 4 days duration, 4 to 7 days, and 8 to 18 days, and more than 18 days duration, this was associated with much higher risk of development of C. diff infection. And so let's look at this again, the worst offenders for C. diff. This was a systematic review back in 2021. What it did was to look at the, again, different classes of antibiotics. And you can see here that the carbapenems, the third generation cephalosporins, 4 generations, which would be cefepime and ceftazidime. And of course, one of my favorite antibiotics in this whole world, the fluoroquinolones, also considers that worst offenders for C. diff infection. So you can see they kind of look very familiar, all right? And so carbapenems and fluoroquinolones, here they go again. So worst offenders for resistance, we've talked about the worst offenders for C. diff infection, and again, they are also considered the worst offenders for resistance. So same antibiotics, more resistance and C. diff infection. And so good news, avoid these antibiotics and reduce your risk of C. diff infection and development of MDRs in your patients versus use this at your risk. So other consequences of antibiotic use would be the impact on the microbiome. This is a topic that takes at least another 1 hour. So I just kind of wanted to mention this. I'm not gonna elaborate on this. But for every practicing clinician here in the room, we are all aware of the diversity of gut microbes, is decreased with C. diff infection, as well as patients that have recurrent C. diff infections. So let's look at the prescribing trends in Nigeria. There's so many studies that I was able to, pull up. And something that stood out to me also would be that the same classes of antibiotics that we kind of worry about here in the US is also, an issue in Nigeria. The commonest would be, the use of fluoroquinolones back home. And then, the penicillins and, the ceftriaxones also is something that is an issue back in Nigeria. So what can we do to stop this? I'm going to stop here because we have other colleagues who will be picking up, and talk about the implications of this in the clinical setting. But what I wanted to do was to kind of lay the foundation of the backgrounds, to our viewers, so people are kind of able to understand where we started and where we are right now. And this is a major, major emergency, because when you have patients that you do not have antibiotics to use, the outcome is going to be poor. The chances are you will lose that patient. So thank you for your time. I'm open to any questions or comments.
Well, since we started, let me just let the audience know that the Honorable Minister, Commissioner for Health, Lagos State is here, Professor Abayomi. Please just welcome him and appreciate him. This is his second year of coming, and he believes in us, and that's why he comes here. Okay, we have other speakers that have arrived since then. Chinelo,
yes.
can you hear me? Yes. I know you have to go. I know you're going to have me run in the morning, okay? So I'm just going to ask if there's anybody on the floor that has any question on your presentation. Do you have the speaker ready? The microphone.
Yes. Oh, okay.
Does anybody have any questions for her? Nobody has questions? Chinelo, you've done a very good job, and it sounds like they understood everything you said. I hope they did. But I really appreciate you, and you can still stay on with us. We want to listen to the other presentations, but we want to let you know that you are very much appreciated, and you can go and prepare for your rounds in the morning, okay? I'll be talking to you in the state, okay? Thanks very much.
All right. Thank you.
Thank you. Thank you. Please, can you give her a round of applause? Thank you. Well, they say charity begins at home, and we brought out the best in the field of microbiology from University of Lagos, Professor Unilola Udiebo, who is a professor of medical microbiology at the medical school, my medical school, where I went to medical school. She's attended this program at least for the last 2 or 3 events, and she's finally agreed to be one of our speakers. So, welcome Professor Unilola Udiebo to give us a little talk on what we need to know about microbiology.
Thank you very much. It's good to be here, and thank you for the kind introduction. Up school, I am very happy, to see my classmates, some of my seniors then here, and my colleagues, at the same university. I'll be talking to us about microbiology of multi-drug resistant infections in Nigeria, where we are at now and where we want to be. Please go on. I'll give a brief introduction, background information, and definitions. I'll highlight the types of MDROs that we have, which, thank God, has been dealt with in the last presentation, and what we have done in that area in Nigeria, in my own little corner, and how we have done a surveillance or attempted a surveillance of MDROs. I will give a few recommendations and dwell on the way forward. Next, please. Antimicrobial resistance, is resistance of a microorganism to an antimicrobial agent to which it was previously sensitive. Such infections, caused by such organisms are more difficult to treat. They usually require alternative medications, or high doses, which may be more expensive or more toxic, or both. Antimicrobial resistance, means antibacterial, antifungal, antiparasitic, and so on. But usually when we say antibiotic, we're referring to antibacterial. And antibiotic resistance is a subset, of AMR, and it applies only to bacteria becoming resistant to antibiotics. And the resistance that is relevant here is acquired resistance and not intrinsic resistance. We know that some bacteria are intrinsically resistant to some antibiotics. In other words, even before such antibiotics come into existence, they're already resistant. So there's really nothing except to recognize them. There really is nothing we can do about such. But when an antibiotic, has been working before and it is no longer working, that's the clinically significant resistance that we're talking about. And we should note, that antimicrobial resistance is a biological phenomenon. It is natural. It will ultimately occur, but we can slow down this resistance. And here we'll talk about selective pressure. Next, please. Bacteria double their populations every 20 minutes. Simple binary fission. But this division, is very high, and it comes with error, which gets replicated very, very fast. In a colony of bacteria, there will be some variants, and these variants will have characteristics that are different, from the mother cell. Next, please. The characteristics, could be in form of changes in receptors to an antibiotic. The antibiotics will need the receptor in the bacterium, to bind, before the work can start. But once there is something wrong with that receptor, then it's bye-bye to the antibiotic. And these variants, tend to be a minority, and their survival will depend on the environment in which they find themselves. If such a colony, finds itself in the presence of that particular antibiotic to which it has become resistant, then it flourishes. The other colonies die. And this selection, this phenomenon we call selective pressure. And it is caused by sustained use of an antibiotic. As long as that antibiotic is there, the organism flourishes. Next slide, please. So when do bacteria adapt? When you give an antibiotic, enough of it, the organism gets killed. So there's no problem. But when there's selective pressure or the antibiotic does not work, you give to a low dose, you give falsified antibiotics. So the organism, some parts of it die. That mutant, that part, there's some parts, that will develop resistance genes in selection pressure. And those variants, will survive and carry genes for resistance. And this occurs, when you give a very short dose. It works for a while, and then the antibiotic is no longer there, or its effect is no longer there. The microbiology managed to develop resistance genes. When the antibiotic is not required, and you give it, it has no effect. But the bacterium has experienced it. And here we may even be talking about normal flora, which are always in the body. They develop resistance genes, and they're able to pass it on to pathogens when they come into the same system. Conjugation and some other ways of transfer of antibiotics, and these genes get passed on. So genes become developed in underuse of antibiotics, in misuse, and also in overuse of antibiotics. Next slide, please. Bacteria are very efficient at enhancing the effects of resistance because of their ability to multiply very rapidly. And they can transfer their resistance genes to, during replication. In a medical setting, such microbes will not be killed by a standard course of treatment. And resistance genes are also passed on through conjugation and vertically too. And this way, resistance to a single drug can spread rapidly through a bacterial population. Next slide, please. We have to talk about this in the hospitals. Yes, we know that a lot of antibiotic use occurs in the community, in animals, in farming, and all that. But why we must talk about this in the hospital, because the hospitals are a critical component of the problem worldwide. When a patient gets sick, with an infection, it comes to the hospital. it comes with its organisms, which get deposited in the hospital. In the same hospital, we use antibiotics a lot, which fuels selection pressure. And in this same hospital, we have patients that are very vulnerable, maybe depressed general immunity, depressed local immunity. And so, in this hospital, where you have a lot of organisms and we do not practice our infection control measures optimally, then there will be a lot of cross-infection. And this could occur, with resistant organisms. Infection control practices such as simple hand washing, wearing of gloves, and asepsis. Next slide, please. So, in the hospitals where you have a combination of highly susceptible patients, intensive and prolonged antimicrobial use, cross-infection occurs in nosocomial infections with highly resistant organisms. And these infections are very expensive to control, and they are actually difficult, to eradicate. Next slide, please. So what are the determinants of resistance? Among other determinants, we have occurrence of resistance genes. This is a crux of the problem. Next slide, please. So here we're talking about genes. Resistance genes are produced, and they are spread regularly. We've talked about mutation, which occurs spontaneously in about 1 in every million divisions, resulting in resistance genes being developed. And we talked about transferable drug resistance. These same genes, can be, we can find in extra chromosomal genetic elements, such as plasmids and mobile genetic elements. They ensure, the spread of this, the horizontal spread, of these genes. Next slide, please. What are plasmids? They are extra chromosomal elements found inside the bacterium. They multiply independently of the chromosome, and they are inherited regularly by the daughter cells. A bacterium can have many plasmids, and resistance plasmids, among other types of plasmids, contain genes that code for transmissible resistance to many antibiotics. So if you have 20 plasmids in one bacterium, you can have resistance to at least 20 different antibiotics. Bacteria processing such plasmids are resistant to many antibiotics, and this resistance is transferred to closely related species through conjugation. Next slide, please. And the mobile genetic elements play a vital role in acquisition and propagation of resistance genes. They include, among others, transposons and integrons. Transposons, can transfer resistance within a cell. For example, E. coli transposon, carries a gene cassette that confers resistance, to some antibiotics. And many antibiotic resistance genes are located on transposons. These transposons are called jumping genes, because DNA can move, from one part of it to another, from one part of a plasmid to another. Next slide, please. Integrons are mobile genetic elements too, and they are genetic platforms that acquire exogenous genes in the form of mobile gene cassettes. Integrons contains a reservoir of genes that can be rearranged and used by cell under selective environment. They can acquire multiple resistance genes in the form of gene cassettes, and they are located in movable entities, like plasmids or transposons, and they are primarily found in gram-negative bacilli. And you can see how genes get transferred very easily, effortlessly. Next slide, please. So then, genes are transferred, either vertically, during replication, of chromosomes get replicated, plasmids too can get replicated. And these genes can also be transferred horizontally through conjugation, from bacterial cell, one to another, transduction, viral mediated transfer. And bacteria, can pick free DNA, from dead bacteria in the environment, transformation. Next slide, please. So how do the work of the genes actually show physically in the bacteria? The physiological mechanisms, of resistance include inactivation of the antibiotic by enzymes. Enzymes are produced by bacteria. You can have enzymes like beta-lactamases that hydrolyze nearly all beta-lactam antibiotics, aminoglycoside modifying enzymes, chloramphenicol acetyltransferases, are also there. And another mechanism is alteration of target proteins such that the antibiotic doesn't bind or binds with decreased affinity. These antibiotics actually have their target cells or target points in the bacteria. It could be the cell wall, it could be protein synthesis, it could be DNA, it could be the outer membrane protein, but these sites can be altered in the bacteria and rendering the antibiotic useless. Next slide, please. An example of that is penicillin penicillin resistance in Streptococcus pneumoniae, even MRSA, methicillin resistant Staphylococcus aureus. And the another mechanism is alteration of membrane, which decreases the permeability of the antibiotic, especially in gram-negative bacilli. And we also have active efflux of the antibiotic. Many classes of efflux pumps have been characterized in both gram-negative and gram-positive organisms. What this means is that as the antibiotic is entering the cell, bacterial cell, it gets pumped out immediately, so that the bacterium is able to evade the effect of that antibiotic. And then we have also development of alternate metabolic pathway to bypass the action of the antibiotic. Next slide, please. So since penicillin was discovered in 1928, we're told in last lecture also, that resistance have been developing to various antibiotics, to many antibiotics. But we have these antibiotics that we consider our last line. They have been our last line for quite a while, at least in Nigeria. No new antibiotics are being produced, really. We also just have modification of the old ones, and they're not coming forth, as much as we would want to, because they are quite expensive, to produce, and clinical trials are very, very expensive. So what do we have to do now? It is to protect the antibiotics that we have, so that through our action, through our stewardship, we can slow down, development of resistance. Next slide, please. Multi-drug resistant organisms are also there, Organisms, can be resistant to one antibiotic, but they may also be resistant to many antibiotics. And this has actually been described. It's a problem that is recognized globally as a major problem in the treatment of microbial infections. Bacteria that resist treatment with more than one antibiotic or with a key antimicrobial agent, is referred to as a multi-drug resistant organism. A typical example is a methicillin resistant Staphylococcus aureus. It is resistant, to oxacillin and the related penicillins, but it is resistant to, it should be taken as resistant to all beta-lactams, to aminoglycosides, and to other classes of antibiotics. And a better understanding of the mechanisms of resistance will help clinicians regarding the usage of these antibiotics in different situations. Next slide. Thank you. It occurs in two ways. There's accumulation of genes on resistance plasmids or transposons, with each gene coding for resistance to a specific agent. You can have many genes on the same plasmids. You can have plenty genes on transposons, coding for resistance to various antibiotics. And there is the action of multi-drug efflux pumps, each of which can pump out more than one drug type. And efflux pumps have been described, that can pump out numerous antibiotics. Next slide, please. And examples, we heard many examples in that last lecture, so I'll just be repeating them, the most common and the most important. There's methicillin-resistant Staphylococcus aureus, MRSA, vancomycin-resistant Enterococcus, VRE, extended spectrum beta-lactamases producing gram-negative bacilli, carbapenem-resistant gram-negative organisms, such as carbapenem-resistant Enterobacteriaceae or Pseudomonas aeruginosa. Next slide, please. MRSA is, Staph aureus is one of the leading causes of invasive infections, which are community or hospital-acquired, and infections are treated most often, with beta-lactam agents. The mechanism of resistance, for MRSA is primarily the presence of a gene, MEK-A gene, which encodes the production of a penicillin-binding protein with a lower affinity for penicillin. MEK-A gene is located on a mobile genetic element called staphylococcal chromosome cassette. Next slide, please. The resistance in this case is not only to methicillin, but to all beta-lactams, and also to aminoglycosides, macrolides, vancomycin, tetracycline, chloramphenicol, lincosamides. And such strains are also resistant to disinfectants. And this can actually act as a major source of hospital-acquired infections. And then you wonder, which antibiotic do you want to use, in this case? For quite a long time, next slide, please, the drug of choice has been vancomycin. Once you have MRSA, you go for vancomycin. But resistance is developing as well, especially to Staph aureus and to Enterococci, in which case you start going to linezolid, or what's the name of this other? Daptomycin. For simple infections that are caused by MRSA, you can still give where you have tested and they're sensitive. You can give a septrin, doxycycline, minocycline, tetracycline. But in case of complicated infection, severe infection, you may need to get to linezolid or ceftaroline, which is a fifth generation of cephalosporin, daptomycin, and clindamycin. Next slide, please. Okay, vancomycin was not in use, for quite a while, because of a toxicity, but it was resurrected, for treatment of MRSA infections, but resistance, like I said, to Staph aureus, is developing. To the best of my knowledge, fortunately, the resistance rate to vancomycin is still low in Nigeria. To the best of my knowledge, but many people are working on this and we're all observing. And what is also important here is that are we really looking hard enough? Are we looking well enough, for all these developments? Next slide, please. Next slide. For Enterococcus, gram-positive bacteria such as Enterococcus, and Clostridium difficile can also be treated with vancomycin, and other glycopeptides, and the resistance mechanisms here involves a multi-enzyme route in enterococcal resistance. It is conferred by several genes, Van A, B, C, D, and E. When the cluster of these genes is expressed, the peptidoglycan precursors, are synthesized. Alternate precursors are synthesized, that replace the usual precursors. And that way the organism is able to bypass the effect of the antibiotic. So here we actually have precursor degradation and substitution, which vancomycin has a poor affinity for. This is the mechanism of resistance here. Next slide, please. Now, beta-lactamases, the production of beta-lactamases is among the most clinically important mechanism of resistance for gram-negative pathogens. The beta-lactamases are enzymes that provide multi-resistance to beta-lactam antibiotics. Beta-lactam antibiotics include penicillins, cephalosporins, monobactams, and carbapenems. What the enzyme does is to hydrolyze the beta-lactam ring. This ring is common, to all the beta-lactam antibiotics, thereby deactivating the molecules antibacterial process. The enzymes are secreted when the antibiotics are already present in the environment. We have some beta-lactamase inhibitors, that are coupled with some of these beta-lactams, and we're still able to use them. But there's still some, that there are no beta-lactam inhibitors for. Next slide, please. Next slide. There are more than 300 beta-lactamases in existence, and there are several classifications, but there's the AMBER classification, which groups them into 4, and I'll only mention, the class A, 4 classes A to D. I'll mention the class A because that's where ESBLs belong to. The extended spectrum beta-lactamases are plasmid-encoded enzymes. They are in class A of beta-lactamases, and some bacteria like Klebsiella, E. coli, and some other Enterobacteriaceae produce ESBLs. And once they produce these EMBLs, they're able to hydrolyze the extended spectrum penicillins, the third generation penicillins especially. The third generation penicillins and the monobactam. Some of them are also able to hydrolyze carbapenems. We've known, that once you see an ESBL, the next antibiotic is a carbapenem, meropenem. But we now have a beta-lactamase, that hydrolyzes carbapenems, a KPC. It is similar to ESBL, apart from the fact that they're able to hydrolyze carbapenems, and these are also spreading. Next, please. Next slide. So for a long time, the drug of choice, for ESBL production has been carbapenems, but we are still, carbapenem actually for a long time has remained effective. And where I work, I know that we are beginning to see, are we just beginning? About 12 years ago, the resistance rate to meropenem, your Pseudomonas in our hospital was about 4%, but it has increased progressively. Today it's about 17%. And we're already talking, about resisting, the use of meropenem, to some antibiotics, and we're hoping, that we'll be able to apply formulary restriction and the pre-authorization as an antimicrobial stewardship strategy, for this. Next slide, please. So carbapenems include meropenem, imipenem, ertapenem, and doripenem, and the resistance, to this is enzyme mediated. Carbapenems, which are a type of beta-lactamase, that are able to inactivate these carbapenems together with other beta-lactams. When you have production of these carbapenems, that you really cannot use, the lower generation cephalosporins and other beta-lactams to treat, because for a long time they have been a last resort to this. And carbapenem resistance is fast becoming a global health problem, that occurs when these organisms develop resistance. Next slide, please. We have heard, we got the list, of important multi-drug resistant organisms, in the last lecture. I just want us to say, that we have been looking in Nigeria, for this MDROs, as they are detected in our routine labs, because that really is where we will be able to make a difference in this. We are participating in global point prevalence surveillance of antimicrobial use and resistance, and we've been doing this since 2015. This tool enables us, to investigate or to survey the rate of prescribing of various antimicrobials, prescribing practices, and also resistance rates, and specifically, to survey multi-drug resistant organisms as they are processed, as they are detected in our laboratories. And this tool enables us to actually get this information from the patient's case notes. We don't go to the laboratory to get this. And every year, we have been doing this. And when we did this in 2015 and 2017, we were able to see all these organisms: methicillin-resistant Staph aureus, methicillin-resistant coagulase negative staph, vancomycin-resistant staph. Enterococcus was not recorded in our hospital. ESBLs were not recorded. Third-generation cephalosporins, were recorded. But I'm just showing this, just not to show that we are able to see them or that these figures are representative, but the fact that we are not even seeing them, we are not able to survey them. Because let's compare, with hospitals in Europe on this side. We can see that, the rates are higher and more of the organisms are seen. Even in the African continent, we can see, we see that all the other organisms are reported, but in our hospital, we are able to report only 3 in that survey. And in Nigeria, the rate is, the picture is not much different, especially when we started out in 2015, but it was a bit better in 2017. This is, there's other MDR, which are not listed here, which was also supposed to be looking out for. But we will soon see why we are not really reporting this. Next slide, please. So what I've said here is that with global PPS, we are not really able to report MDROs as we should. But this at least tells us that they are with us. I think that's the information here. But the figures are not representative. And the reason is that there's a gross underutilization of microbiology laboratories in Nigeria. We'll see more. Next slide, please. So what's the role of the laboratories in managing multi-drug resistance? The lab is responsible for accurate and actionable reporting. The lab is supposed to play a key role in ensuring appropriate infection prevention and interventions. They provide the initial information for this, and the information they provide also guides us, to when patients require isolation and contact precaution. Because patients that are infected with MDROs are actually supposed to be isolated, to limit spread of such organisms. And they also point to appropriate treatment pathways and they enhance reporting, to a larger body, antimicrobial stewardship. Antimicrobial stewardship committees, IPC, and nationally. Next slide, please. Okay. Okay. Please, can we, sorry, my slides were a bit disorganized, when I first came, and this is the first chart I showed was, what we got in 2015 when we first started, and this we got in 2022. And we can see that, we reported a bit more, than we did in 2015. But it's still not enough. And for our hospital and compared with Nigeria, well, we reported more in Nigeria, which means that other hospitals are reporting a bit more, but the figures are still quite low. And they cannot be representative. Next slide, please. So the role of the laboratory is also diagnostic stewardship, which refers to coordinated guidance and interventions to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. It should promote appropriate timely diagnostic testing, including specimen collection and pathogen identification, and accurate and timely reporting of results to guide their management. Next slide, please. The main objectives, of diagnostic stewardship is clear, is to guide patient management by timely microbiological data and to provide accurate and representative AMR surveillance to inform guidelines. Next slide, please. So we've talked about MDROs, and the determinants of resistance. How do we then solve the problem? We know that among others, a key determinant is occurrence of resistance genes. Therefore, what do? We need to do a surveillance of resistance so that we can actually appreciate the magnitude of the problem that we have. Next slide, please. And this problem is actually addressed in antimicrobial stewardship. The goals are quite simple, to monitor and manage antimicrobial use, but ultimately to reduce the risk of development of antimicrobial resistance. Next slide, please. Next slide. So there are information that we need for antimicrobial stewardship. If these informations are not provided, we won't really get anywhere. We need to know the resistance patterns of pathogens and to be able to correlate the resistance with antimicrobial consumption. This is where we start. And as we introduce interventions, we need to monitor and evaluate. Next slide, please. Well, I've talked about the use of global point prevalence survey, and how we have used it in Nigeria for stewardship, and for diagnostic stewardship. Next slide, please. Yeah, I want us, to take the slide away. This information I'm about to give away, if we don't take anything else, from this presentation. And it is that the global PPS we did over the years enabled us to appreciate the fact that we are prescribing antimicrobials at very high rates, despite the fact that we are poorly using our microbiology laboratories. And the information on the multi-drug resistant organisms that we intended, to get is not possible. It is because patients are not really being sent to the lab. They're just prescribed antibiotics. Next slide, please. And when we saw this, we then proceeded, to find out why doctors are not sending patients to the laboratory. And we administered a questionnaire, to investigate this at the ASCAF in 2018. Next slide, please. To actually ask specialists, why, despite the fact that they were prescribing antibiotics at very high rates, they are not sending patients to the laboratory for cultures and all that. Next slide, please. And these were the reasons, that they gave. There are two types of reasons. There are two sets of reasons here, as shown, in the font type. There is one that is based on the mindset of the doctor, the prescriber, and one that is based on the laboratory. Clinical diagnosis is sufficient for me in almost 40% of patients. They just won't. Patients cannot afford the cost in another 20%. Which means that instead of counseling your patient, you prefer to state the patient's case, if not. These are patients that will sometimes go to the laboratory, go to the pharmacy before they even get to you. And some of them felt, I already know the potent antibiotics and there's no need for tests. And I don't need the laboratory to manage the patients. The other points just speak to the fact that, that we have to improve our practices in our laboratories. So what's the way forward for us? We need to embrace antibiotic policies. we need that behavior change. We need to send our patients to the lab, so that we can actually know what we are dealing with. If we don't know what we are dealing with, we just be groping in the dark. There's need for diagnostic stewardship and antibiotic stewardship. And lastly, I don't know how we are going to do this. Now, we have to come up with national and local strategies on reversing the trend of underutilization of the microbiology laboratories. I have talked and talked. We have talked and talked, but we don't seem to be making progress. So maybe collectively we will make progress. Thank you very much for listening.
Thank you very much, Professor. That was very brilliant, and we appreciate you very much. We'll ask you questions later, okay? If you don't mind, okay? Yes. Well, that was a very exciting session in the field of microbiology. We appreciate you. Thank you very much. I just want to read this to us. One of the participants said this to me just now. It says, the importance of this topic we are discussing today is a worldwide concern, okay? And recently, global leaders have approved the political declaration at the 79th United Nations General Assembly high-level meeting on antimicrobial resistance, committing to a clear set of targets and actions, including reducing the estimated 4.95 million human deaths associated with the bacterial antimicrobial resistance annually by 10% by 2030. Well, as we all know, this is a scourge, and we're all in it as patients, as physicians, as microbiologists, as pharmacists, to battle this scourge. Hopefully, we'll win with all these kind of efforts we're making. Well, we have to move on to the next speaker now. Dr. Folake Kofo-Idowu is a US-based physician, infectious disease specialist like myself, who actually flew in from the US to just be part of this event and present, at this meeting to us. We appreciate her very much. She went to University of Maryland to do her internal medicine, and but she works as an infectious disease specialist in America. She has a lot of initiatives that she's doing. You can read her background in here. But she's going to be talking to us today on the navigation of drug-resistant infections from antibiotic stewardship to innovative therapies. She has promised me that she's going to stay to the 25 minutes, and she won't exceed that, because we have a lot of breakfast that is going to waste. So we can have some time for breakfast, okay? Thank you. Dr. Folake Kofo-Idowu.
I guess so. Good morning, everyone. I hope we're having a great morning so far. Oh, yeah, my slides are up. So I'm Folake Kofo-Idowu. Just like he said, infectious diseases specialist. I graduated in Lagos, so don't worry, I'm not too foreign. I graduated from LASUS, and then I did advanced training in the US. So today, I'm just going to be talking to us in terms of hopefully practical terms. How do we navigate and take care of infections that patients have? Next slide, please. So there's been talk, people have talked about the numbers, but again, it's a global problem. It's not just Nigeria. And in Nigeria, we're probably not even capturing enough of how much the issue is. Next slide. I don't want to belabor us with that. But one of the first things, just moving right into it, is what we call antibiotic stewardship programs. And antibiotic stewardship is just a coordinated effort that involves multiple specialties or multiple team members in a hospital or a clinic to be able to implement evidence-based practices that have been tested and tried, right? And they use them to reduce the infection rates and also they promote responsible use of antibiotics. So how do they do this? There's 5 Ds of antimicrobial stewardship. And the first one is using the right drug. Professor Oduyebo here, was talking about using the microbiology lab. You cannot be sure you are using the right drug if you have not tested it, right? They talk about MRSA, they talk about VRE, or sometimes vancomycin-resistant enterococcus is sensitive to ampicillin, right? And then you're going high, costing the patient money, using bigger antibiotics. So using the right drug is very, very important. Using the right dose. Are you underdosing? If you're not giving the right dose and it's not killing the antibiotic, the bacteria well enough, then it learns how the antibiotic can affect it and develops resistance. So appropriate dosing matters, because when something is slightly resistant, like daptomycin, we use 4 milligrams per kg for one type of infection. We use 6 milligrams for one type of infection, and sometimes we use 10 to 12 milligrams for some type of infection. So you need to know what you're dealing with to pick the right drug, the right dose, the right route. We know that many of us take antibiotics by mouth. Some of us can take antibiotics, maybe inject into the skin, put a cream on, IV. There are people who also get antibiotics through a catheter that's already maybe placed in their spine and things. The point is you need to know what kind of infection you're dealing with, what location of your body, because of what we call pharmacokinetics and pharmacodynamics, which is basically how the drug moves through your body and what your body does to the medication as it's moving. When we swallow medicines and it goes through our belly, our stomachs, it moves through a process that sometimes it reduces the amount you swallow. So the amount you swallow is not what gets in the blood. And what gets in the blood also has to circulate and get to the right point. So it means that if you're taking something that if you need 100% of it to get into the blood, IV might be your best route. There are some medications that we're lucky, a few of them, that when you use them by mouth or you use them by IV, you get the same amount in the blood. We call that bioequivalence. But again, if you're not trained, you don't know. So you just tell someone, yeah, go and take this, but it's not enough to treat. And what now happens is you are underdosing the person, and it takes you back to not giving the right dose. So everything is connected. The fourth one is duration. Are you under-treating by telling someone to take antibiotics for 3 days? Or are you a patient that they tell you to take antibiotics for 5 days, you take it for 3 days, and you're like, I feel fine, so I'm just going to stop and keep the rest for later in case something happens? That is very, very wrong practice. Because what has happened is you have not cleared the bacteria from inside your system. There's remnants of it. Your body might take care of it, but that bacteria, best believe it has learned a trick. And next time it's going to be resistant to that same antibiotics. Finally, is timely de-escalation. And it's not necessarily contraindicating the fourth point, which is duration, but it is that when someone is sick and we're not sure what's going on, obviously we're not going to wait for lab to give us answer. We have to do something now because we need to save your life now. So there's something called empiric therapy that we use, and it's just we make a best guess as wide as possible and give something. And within 48 hours, you should start getting information from the lab or from other diagnostics to say, okay, this is where it is, this is the suspected bacteria, and then you start de-escalating, right? So timely de-escalation is also important so that you don't expose the person, their normal microbiome and other bacteria that may be present to antibiotics unnecessarily. And the benefits of that, again, you just you reduce unnecessary consumption of antibiotics, you make sure you have appropriate use, and this helps in reducing or slowing the development of resistance. And of course, if you're not developing resistance, it means you're preserving the antibiotics you have, and this eventually improves patient outcomes. Next slide, please. So these are just a list of some new antibiotics. So the next strategy, like I said, first one is antimicrobial stewardship. The next is new antibiotics, novel antibiotics. Of course, so many researchers are working so hard. And thankfully for AI, the time to development for antibiotics is getting shorter because AI is helping us be able to shorten the time, blah, blah, blah. But these are some of the antibiotics, that are new, fairly new, maybe a few years old, and we have things like oridavancin, dalbavancin, and those ones are good. They're kind of like a modification of vancomycin. They're good for MRSA infections. We have daptomycin. It's been around for a number of years. You know, we use a lot of gentamicin around here, and we have modifications of them that are not as toxic. And then there's some other ones, you know, Professor Diabo mentioned, ceftaroline, other medications in that 5th generation. We have cefiderocol, which is a lifesaver when you have all these carbapenem-resistant discs, pseudomonas, and you are having palpitations literally. So some of these medicines are lifesavers. Next slide. Another strategy is combining, right? And in combining, it's usually combining an antibiotic that's already in existence with something that's relatively new so that they can work together, sometimes to achieve the same level of results just because one is weaker, or sometimes to achieve a higher level of results. And that's, you know, synergism. And sometimes it's pre-designed. So we have antibiotics, we've heard of Zosyn, piperacillin, tazobactam. It's a pre-designed or pre-joined. So you get that one medication, but it has 2 drugs in it. We have meropenem vebobactam, which is Vebomer, ceftazidime, avibactam. So these are pre-designed, but there are some that at the point of use, you can combine. If you have, for instance, a gram-negative bacteria, sometimes even a gram-positive bacteria. I've had to treat MRSA, and the person's blood for like 2 weeks is just positive. And you can't just continue to give one medicine. You need to hit it hard, and so you combine 2 MRSA medications. And just like when you have very resistant gram-negative organisms also, sometimes at point of use, you're giving ceftazidime and you're giving meropenem, and it might be intermediate or resistant to one, but the trick you are doing is you are distracting the bacteria with one. It's busy trying to break one down, like, oh yeah, I can kill you, I can deal with you. And as it's doing that, you're using the other one to disarm it and treat your patient. Next slide. So, you know, there's benefits to that, which is, again, you're improving patient outcomes, and it's reducing resistance development. These are now the interesting parts. Alternative therapies, right? And these alternative therapies are now using non-traditional approach. Traditional approach is just antibiotics. And these are like things like phage therapy, immunotherapy, using special peptides, host-directed therapies, antimicrobial peptides also, and then metal-based. So I'm sure we've heard of like silver dressing and things like that. But again, they've now raised it up a notch to make them into things like nanotechnology-based. And this has helped in the effectiveness. Next slide. And on that slide, I'm going to focus particularly on 2 to 3 of them. Next slide, it's okay. You can take it. The first one is phage therapy. Phage just means to swallow, right? So you have macrophage, you have this phage, you have that phage. Bacteriophages are viruses that can swallow bacteria. Literally, it's very simple. So this kind of therapy uses viruses that can infect a bacteria to target and kill them, because that's what viruses do. They go into a cell, they take over the mechanism of that cell, make it useless for anything else, and just use it to produce their own babies. And that cell is, and once they are done, poof, they burst the cell open, that cell is dead. So they just replicate themselves. And what it does is that it is a very specific treatment. It targets that particular bacteria that's giving you a headache, and it has rapid replication because they go in, they multiply, destroy the cell, and go and infect another cell. And it just keeps going, boom, 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 till they reach their own end of their own lifespan, and maybe you need to give another dose. And for this one, because the rate of developing resistance is slower, it means that there's a limited rate of resistance development to bacteriophages. And also, they give an advantage where you can actually combine them with other traditional methods. So you can combine bacteriophage with antibiotics. The challenge with that is that there are regulatory hurdles. A lot of these are still in development, and most of the time they are translational research. So it's going almost from the lab to the bedside, but it's in special cases. And because of that, it's not something that's widespread and it's not commercialized. The development process also, it requires a very rigorous and meticulous selection of the bacteriophage you are going to use, because you don't want to go and give bacteria a virus that would now cause another problem, right? So you want it to just do what you're asking it to do. So there's a selection process. You need to prepare it to remove all other virulent factors so it doesn't cause other problems. And then you need to test it with that particular bacteria to make sure it can kill that particular bacteria. So this is on a case-by-case basis. And then there's standardization. Because it's very tailored, if 3 of us, God forbid, but if 3 people have multi-drug resistant Pseudomonas, we may end up getting different variants of that phage therapy. And so because of that, standardization is difficult because you need to tweak it each time to each person. So research, a lot of work still needs to be done to find maybe components of that process that can be replicated en masse. And finally, it's just delivery systems for that in terms of, for now, it's only IV. Can we deliver it intrathecal for intracerebral infections or spinal infections or intra-abdominal? And those are still under development. Next slide, please. Host-directed therapies. Just to save time, I actually combined 2 things here, but I'll do my best to separate them. And this is basically targeting host immune response. You and I can have an infection, even bacteria. I've seen people who had bacterial infection, and the guy is like, yeah, I've been having fever, this, that, and he's not using anything. So his body is fighting it, but his body is just not doing enough to get rid of it, right? So it means that our body can do something. It just needs help. And so in different people, or maybe in people with suppressed immunity, or even sometimes just regular average Joes, we can stimulate their immunity, specific parts of your immunity, to improve or enhance our response to bacterial attack, right? And that makes, again, easier for your body to be able to clear. Sometimes also, some of the therapies or some of the strategies is that they inhibit the virulence factor of the bacteria. Bacteria comes into your body, it stimulates one particular thing, and it signals your body, and your body is going, crazy. So sometimes the therapy is inhibiting that stimulation part where, okay, you are not coming to knock on this door, because once you knock this door, this is chaos. So there's a blockage that happens. And of course, we know that the inflammatory process, when there's an infection, your body is going crazy, trying to fight. Okay, bring all the soldiers, bring the colon is red, is painful. So we are able to also target the immune response to reduce the inflammation that happens. The immunotherapy part is active immunizations and passive immunization also can be used to target bacterial infections. Of course, active, we don't have, well, that's a virus, but active immunization, so using monoclonal antibodies, IVIGs, can be used for this. And of course, immune checkpoints, either the ones that enhance allow the bacteria to proceed and do harm, or the ones that inhibit the body's response so that the bacteria can wreak havoc. Those things can be modulated. And there's metabolic interference, because again, sometimes it's not just physical, box me, I box you. It might be stimulation. For instance, in cholera, what cholera just does is it turns on a switch and allows your body to just waste water. That's literally it. So that's a chemical processing, and then, they can give modulation that now says, oh, this switch, what we're going to do is close this switch, and it alters that metabolic process in there. So sometimes it's not just one cell is boxing another cell or swallowing another cell, but there's chemical processes that can be inhibited. And then we talked about virulence factors also that can be modified. Next slide, please. Now, here we have nanotechnology. There was a lot more, but I tried to limit it. And for nanotechnology, A lot of it is just modifying or improving on current things, like drug delivery, right? How do you get the medicine from one point to another more efficiently? I mentioned bioavailability. So if you give a medication, even if you give it by IV, it will still go through something, and you want it maybe to last longer, or you want it to be preserved till it gets into the brain, till it gets into the bone. You can modify those with nanotechnology, nano-based particle drug delivery, and this covers it in a way that your body cannot digest it till it gets into somewhere, and maybe there's a special chemical somewhere that's able to open it up and all those fancy stuff. Some of these things are already existent. They're not too new, like liposomal amphotericin B. We use that a lot for fungal infections, but antimicrobial creams also, because you put that on the skin before it gets into the blood, a lot of things can happen, but nanotechnology can help with that. Nanoantibiotics also is just designing nanoparticles and putting them as part of the antibiotic structure, again, to improve their efficacy. And nanostructured surfaces. This is actually quite interesting because medical equipment, medical surfaces, right? So, for instance, this is, it's antimicrobial. Hepatitis B is so annoying because if a blood of a hepatitis B person drops on this thing, if you leave this thing for 30 days, that virus is still alive. Exactly. So you have to be careful, right? So when people are saying wipe all surfaces and those things, they're valid. But imagine there's a spray like Lysol, Jik, Hypo, whatever it is that people use, but you have one that is nanoparticle based, and you wipe that surface such that when any microbe drops on it, the thing itself has antimicrobial embedded in it and it can kill, right? So this will be very good with clinic surfaces, even OR, we're a resource limited place. Imagine you are in some Kutuwenji place, you don't have, a lot of resources for sterile this, sterile that. You can just wipe, right? And you can be assured that, okay, before starting this quick procedure, you wipe and everything is clean. So that helps. But they can also coat surgical instruments, right? Because sometimes one sterile something did not sterile well, and then you introduce bacteria during the surgery, or you're just doing one quick suture, in clinic, and they're doing things all sorts of places. So some of maybe the suture or the equipment are lined such that any bacteria that gets in contact with it doesn't stay, and it can kill it by itself. And then there was one other thing on nanostructures that came to my mind and I just skipped it. But anyway, water purification. This is a bit more public health, but I put it because it's very relevant. And that's because, not to scare you, but there's bacteria in all our water. Because our sewage system goes into the water, and everything that is in our body, water, whatever it is, we put it in the sewer, and it goes there, and we're recycling these things. And so, are we filtering out bacteria and viruses from the water we use to bathe, to drink, all of that? And a nanoparticle-based water purification system can reduce the amount of these bacteria as much as possible. Yes, one other thing I wanted to mention, I just remembered, is also with nanotechnology in designing certain intrinsic microbiologies. So when you have a foreign body in a human body, like a Foley cath, this person needs, rod and screws for their knees. It is a foreign surface. Anything that is foreign in your body raises an alarm. And your body is just trying to figure out, what is this? What are we going to do? So they start forming all sorts, sticking to it, building this, building that. And there's something called a biofilm. Unfortunately, a biofilm is like a thick, dense web. Once bacteria is stuck in the middle of it like this, it is worse than Sambisa forest. And you need to get stuff inside. So nanoparticles, nanoantibiotics can go deep into those biofilms and kill the bacteria, and sometimes even break down the biofilms, because you treat the infection around it. But when something is stuck, they will just hide there and like, oh, danger is gone, and they come back again and start replicating. And you'll be like, we've been treating this man now. You treated long antibiotics 3 months, and then the man comes back 1 month later. Problem, right? So these are very helpful. Next slide. I hope I'm not over time. Okay, this is my last slide. Where do we go from here? Because we're in Nigeria. What are actual practical steps that we can take? There's been some talk about antimicrobial stewardship, and it's very, very important. We need to train healthcare providers. Honestly, I'm not trying to dig at anyone, but all of us need to do better. I wrote a paper once about acute febrile illness. Not every fever is malaria, and not every fever is typhoid. Sometimes it's just a virus, and it's a cold that will go away, and it doesn't need antibiotics, right? And we all need to just learn some of these things. Developing antibiograms, which is a chart that changes with time in terms of either your hospital or your environment. What have you been seeing on your cultures? What is their sensitivity? So that, especially on an empiric level, you can make informed decisions. Improving infection control and prevention, even for household messaging, promoting hand hygiene. We would be very surprised at how much just washing your hands help. I have nieces and nephews, and those daycare infections, oh my God. Oh my God. You see those children running around, you are an adult, you are wondering how they are surviving it. And getting children to just wash their hands, these habits form with them. I have one nephew that the moment he comes back, he got so used to it. The first thing he does is just pull up his sleeves because he's been taught to do it. And as an adult, I had to also take that. And it's amazing how much it helps reduce infection, just hand cleaning. Hospital environment. Do we isolate sick people? You go to a general hospital and a lot of hospitals, and everybody is in an open ward. The person that has MRSA and the person that has CRE, and somebody is touching this and touching that. So we have to put in place policies and guidelines to test and isolate as appropriate. I'm going to skip to enhancing diagnostic capabilities, rapid diagnostics, point of care. What are things we can do? Because if you have blood culture, is MRSA positive, you can do some kind of DNA-based testing, genetic-based testing that can quickly tell you, even before the bacteria grows out completely, once it detects something, it can tell you, oh, this thing has a strain of this genetic material. We found this genetic material, and it's telling us that this thing is resistant, right? And you can quickly change your therapy. Laboratory support and strengthening. And this is challenging because a lot of our labs, there's regulations, but people are still cowboying things, and there needs to be strengthening and support of them. And I'll talk a little bit about that under policy. Just promoting access, oh my God, to essential medicine. Unacin, ampicillin sulbactam is probably older than I am. And in this Lagos, we were looking for Unacin. And that is a supply chain problem. It's not even stuff we should be talking about here. But these are the realistic problems that we're facing. So affordable antibiotics, but supply chain management, so that even things that can be treated with smaller antibiotics can be, not that, oh, we can't find Unacin, so we're going to go for the heavy hitters. It's unnecessary. Surveillance and monitoring, data. We need to collect data, we need to analyze them. This helps us to track appropriately what we are developing. Like, we are developing Gorillabacters and we know what we're going to do. It helps us to identify emerging threats and look at the trend so we can plan. And it helps in policy decisions. Community engagement, I talked about that. Educating people to be aware, but also promoting behavior change. Research and development. My voice went down on that. We do need it. We might not have enough of it, but we really can do it. It just takes someone who wants to and who is committed. We really can do it. We have labs that are doing good work, and I think maybe the government might help, and well-meaning researchers and clinicians. We have a lot of Nigerians in diaspora who are working on things like this, and we can collaborate. We might not develop new antibiotics, but what about alternate therapy? We can give IVIG. We can find bacteriophages that work. Again, things that are specialized, and we can work on them. They're not rocket science. Honestly, they are not rocket science. My last point is policy. Our Honorable Commissioner is here, and this is not particularly directed at him, but I know he's a very proactive person, and it's just what can we do policy-wise to limit unguarded sales of antibiotics, because we know when I was younger, people used to hawk. You know, I would see them, they used to hawk ampicillin, and then you find out that, in one corner of one building, they were putting curry inside tetracycline pills. How do we limit all those things? Because these are the things that are killing people. Data, some data is being collected, but a lot of it is siloed. People don't even know what is out there. So data and reporting, especially by labs. A lot of labs are testing, private labs. What are they doing with the information? In addition to the labs, there need to be some kind of auditing. I was working somewhere. The lab was doing cultures. 2 weeks, they didn't send us the results. Exactly. And you're like, it was just unfathomable to me. Like, you know, you cultured, so and you're holding on to, the person could have died because you didn't release the results. And so some of these things, auditing on their processing needs to happen. And there needs to be penalty. Because if there's no consequence, everybody just does whatever they like. Antibiotic stewardship programs. What kind of policies can we put in place to start stewardship programs in hospitals to help them improve? And physicians are probably going to hate me for this, but can MDCN institute some kind of mandated CME for us to revise every year when we're renewing our license on appropriate use of antibiotics? That's one way for antibiotics. So next slide. I think that is my last slide. I will keep it there. So the point of my thing is just, it can be as simple as just regulating and observing and auditing, and all the way into like really high-tech stuff of AI supporting new antibiotic delivery, or having phage therapy and viruses. So thank you very much.
Fantastic. Is she not wonderful? Is she not smart? So, this is the generation that is going to take over from old people like me. So, you've done a good job, and we're very impressed. You know, thank you very much. We're not going to be asking our questions. Professor Udiebo is going to be leaving. And from our talk, if you have any questions for her, you know, she just wants to answer the question before she goes. She has another meeting that she has to attend. So, do you have any questions for Professor Udiebo?
I want to thank you very much, Professor Udiebo, for that exciting lecture. But I have two questions, and that has to do with how do you resolve a situation whereby there is an overexpression of ABC transporters in the phase 3 drug metabolism. Overexpression that causes the modification in the clinical pharmacokinetics of antibiotics. How do you resolve that? Because in itself is not drug resistance. The situation presents as drug resistance, but it actually has to do with host genetics. Because the same drug will work for another person. How do you resolve that clinically? Then the question number 2, I'm talking about the ABC transporters, the efflux. Then the next one is your surveillance. Does your surveillance include soil? Because sources of drug resistance can be from manure, you know. Thank you very much.
Hello. Thank you for the questions. Let me start with the second one. I understand that one. We'll go back to the first. The first is, did we sample soil in our surveillance, if I understand the question? No. What we did actually, was to surveillance of antibiotic use in patients. Surveillance of antibiotic use in patients and resistance. Actually, surveillance of multi-drug resistant organisms. And so we did not look at soil or the environment. It was not a surveillance of environment. And it was a good thing, because it was done, as part of documenting baseline information for our antimicrobial stewardship, and also for monitoring and evaluation of our antimicrobial stewardship. And what this shows us actually is that we cannot really do antimicrobial stewardship without embracing diagnostic stewardship as the cornerstone. We will need antibiotic guidelines to do stewardship. Using antibiotic guidelines means for empiric therapy, we based a prescription on information. It means that we already have a good profile of resistance patterns or sensitivity patterns of antibiotics, and we have done our guidelines. The choice of antibiotics I want to use in every case of infection, we have it documented. So we have this case, and there's no time to use laboratory tests, then we consult the guidelines. But first, we have to develop the guidelines. And developing the guidelines means having representative antibiograms, as the basis of our guidelines. Now, if we do not have information, how can we do a guidelines, antibiotic guidelines that truly makes sense, that is truly representative? That is what that was about. So we did not look at the environment or the soil, for survey, but we also looked at the patient's case notes, to see a sort of audit to see what we actually have been doing, so that we can improve our practice. And what we found out, was that we are not using the laboratory enough. Now to the first question. Please, can you ask again? I don't really understand that question. And I don't really understand it. Perhaps somebody else understands it and can help.
I can say it again. Can you hear me? I'll say it again.
Okay.
In drug metabolism.
Drug metabolism.
Yes.
I'm a clinical microbiologist.
What?
I'm a clinical microbiologist.
Okay, ask your question. Ask your question.
I said in drug metabolism.
Oh, okay. Drug metabolism.
In drug metabolism.
Drug metabolism.
There are three phases.
There are three phases.
Three phases.
Yes.
The third phase is the one for efflux transporters, whereby drugs were not concentrated into the cell for them to be active.
Oh, okay, yeah.
And some antibiotics have failed. So many drugs have failed due to that.
Yes.
So it will appear as drug resistance.
It will appear as
drug resistance.
Yeah, it is. But it is.
But in itself, it's not drug resistance. It's just host genetics.
Host negligence. Host the bacteria. No, that's a straightforward resistance. You know what is... Okay, let me allow you to finish, please.
So what I'm saying is this. It modifies the clinical pharmacokinetics and is specific to each patient.
Yeah.
There are new things really, and there are a whole lot of antibiotics that are being involved now. I hope I'm clear.
Yes, yeah. It is clearer to me now. Thank you very much, and thank you for making it easier.
Oh,
yes.
Somebody else can answer.
Yes, my sister here will add to what I have to say.
Thank you.
But I will just insist, that is a clear form and documented mechanism of resistance. The drug is not getting to where it should. And that is the, efflux. The drug is being pumped out, and that is the way the organism is able to sidetrack the drug. We need a better drug, that's all. We just need another drug, to do that job. That drug will not work in that patient. In that particular situation, it will not work. We will need to use another one. Thank you, please.
Okay, thank you, Professor Banjoko. You've confused all of us. That's okay. If you knew the answer, you should have given it to us, But Professor did a very good job. Thank you very much. Well, in the quest of, my auntie has a question. Auntie Biodun Obaki, all the way from Abuja.
Let me seize the opportunity to say well done.
Thank you, thank you.
I like your legacy.
Thank you.
And by the grace of God, we will continue. Professor Ma, in view of the situation of Nigeria today and all over the world, the fact that to eat is a problem. And when you get sick, you either not even buy the drugs at all, or you buy the one that will not take you for the complete dose. Professor Mrs., you mentioned about local strategies. So how do we go about this? Is it to do prevention in terms of herbs? We have a lot of herbs and teas that people are using today for so many disease conditions. So how do we go about this? Prevention is better than cure. We have so many teas. In fact, when you go to the internet these days, they tell you mix ginger, you mix this, you mix that, you mix garlic, so many roots and leaves. We are encouraged to use it. So how do we bring this to the work and to the society because of the prevailing situation in our country today? Thank you.
Thank you very much, Ma. I think I will stand up to respond to that question because I find it interesting. And I like the fact that it is a very practical question. Because we are facing things in Nigeria, it is not easy to live in Nigeria right now. Our salary is the same, and the value is decreasing. Things are getting more and more expensive every day. And yes, we can say be smart, about spending your money, but do you even have the money? And are you able to retain it in your hand? But please don't forget, what I try to preach, is the fact that we should not put the cart before the horse. And that we should try to get information, relevant information, for these multi-drug resistance problems, that we are trying to solve. We are not able to get that information. And all of us here in Nigeria have contributed to that. We need, enough information on the types of infection that we are having, the type of organisms, the antibiotics they are resistant to, the antibiotics they are sensitive to, so that we can use this knowledge to solve our problems. We can use the information to treat patients as they come. But, if I, as a citizen of Nigeria, I feel that, look, I don't have money to go and spend in hospital. I have to be wise about spending my money. And I'm having fever, and I'm having pains, and what I do is to go to the laboratory next door. I've gone there to spend money, the money I could keep in my pocket. And they will tell me that, they won't tell me nothing is wrong with me. They will tell me, look, let's test you. Maybe it's malaria. or typhoid, or malaria and typhoid, or a little bit of malaria and a little bit of typhoid. You will take that result and then you go to the pharmacy to get an antibiotic, that may not even really work for what is wrong with you. And you have spent money. It is still this same money, that we are not having enough, that we are spending. And well, we could be lucky, it may just be a viral infection or something simple that does not even need anything. We just need to rest. We need to distress, and it resolves. Or it could be the beginning of something more serious, maybe a severe infection. And then we have changed the picture before we go to the doctor that will tell us, the correct situation of things. The doctor collects your sample, he sends it to the laboratory. But there's nothing there again because you have gone to the laboratory and you have taken drugs for it, and that has changed the picture, that the doctor should see. And that doctor at that point is discouraged. The next person that comes, if we send sample to the lab, they will tell us no growth. So he doesn't send the next one and others. But if we all decide, to do what we are preaching in Nigeria now, if you have an ailment, go to the hospital. Let the appropriate course take place. Let the doctor examine you. If you need a test, let the doctor send you. And take the result back to the doctor who will interpret correctly for you. Because if you decide to start spending money on your own, you would have spent a lot of money. By the time you go to the doctor, you will even spend more money. I hope I have said something.
Yes, thank you very much, Professor. Thank you very much. You've done a very good job. We appreciate you. I have the pleasure of calling on Professor Akiabayomi, the Lagos State Commissioner for Health, not one term, second term. He's a great man. He was here for our last edition. By the time he finished the last presentation last time, the conference was over, and everybody said they had enough. His deliverance was perfect, he was succinct, and I was very, very proud of him. He's agreed to come back again to do the same thing for us this year. It's a pleasure. He's a very busy man, so he's left a lot of things for him to be here this morning. I appreciate him. Less of talking. Less of talking. Less of talking. Please. Let's listen to the professor. I don't need to read his accolades or everything he's done. Is on the thing here. Professor Abayomi, we appreciate you and we welcome you to the stage. Thank you.
Good morning, everybody. Thank you very much, Dr. Folarin Olubowale, for inviting me again to this session. I enjoyed last year's conference, and I'm sure from what I've heard already, I'm already enjoying this year's conference. You have a way of choosing topics that make us think and make us understand that we still have a lot of work to do in many dimensions. I enjoyed the talks so far, and I'm always happy to see my good friend, Dr. Shei, who's always bombarding me with personalities, ideas, and suggestions. He's very passionate about what we describe in Lagos as the brain gain strategy, which is essentially to make Lagos more attractive to our thousands of medical professionals that are hovering in the diaspora waiting for an opportunity to perch back in Lagos, hopefully in Lagos, but anywhere in Nigeria will do. I enjoyed the talk by Professor Oduyebo. Thank you very much. I think she's left. And I also enjoyed the last talk by Dr. Folake Idowu. In fact, you touched on so many points that I'm going to talk about. I thought maybe after your talk, I should just have my coffee and go home. but I will elaborate on certain points that you made, which are very, very important. I'm joined here with some of my staff, Dr. Tony, Dr. Ademolu, Titi, and Michael. So they're some of the staff that work with me in my office and allow me to get around town in good time and to the right place. So I think you're changing my slides for me. So I was asked to talk about antimicrobial. Oh, there's somebody here that I should mention. One of my very good friends and colleagues from government, Mr. Martins. Thank you very much. I spotted you in the past. Please stand up so that people can know who you are. One of the most important people that have been in government over the past 15 years. He's worked in so many ministries and has done so much for our great Lagos State. I see a lot of youth coppers. I'm always happy to see you. We're very Lagos State. Our governor is very much into the youth and into the female gender. So I see on that table is just a bunch of female youth coppers. So thank you. And there's one more at the back there, another one. Where are all the male youth coppers? Okay, there's one here. Yeah, totally outnumbered, but that's okay. I think they say the brain power now resides in the XX genomic constitution. All right, so let me have my next, thank you. So basically what we're trying to do in Lagos when it comes to biosecurity issues is to build what we call the Lagos Biological Shield. And I'll elaborate what that means. Next slide. But essentially, what we know in Lagos is that we've had a series of waves of biological threats. And it's important for us to be ready for those threats because those threats can come externally or they can come internally. And they can come in many formats. In the last 10 years, Lagos has experienced significant biological shocks. And so we in Lagos are beginning to think, next slide, about how to proof Lagos. May I have the next slide, please? And we need to talk about what these pathogens are. We need to define them. We need to understand their risk. We need to understand their impact. We need to be ready with countermeasures. And we need to have a long-term strategy. Next slide, please. So let me just give you a very high-level definition of what a biological risk is. We refer to it in medical parlance as a pathogen of high consequence. It's a group of bacteria or viruses or parasites that pose the highest risk to national or state security because they're easy to spread. They don't particularly have a defined treatment. Sometimes we may have a vaccine, but quite often we don't. They result in high morbidity and mortality. And very importantly, they can cause social disruption and economic downturn. So, some of these pathogens, as you've heard from the speakers, require sometimes some very advanced environments to work on them because they're not only dangerous to the individuals that are working on them, but they're also dangerous to the environment, and we have to pay attention to how we dispose of some of the effluent that comes out of these laboratories. Next slide, please. And so they have classified some of the 10, I mean, this is just, there are many more when we talk about existential threats. But these are the common ones. What are the biological threats since the last 10 years that we're experiencing globally and locally? Air pollution, non-communicable diseases, pandemic flu, fragile, vulnerable settings. And number 5, antimicrobial resistance. So it's definitely high up on the list. And if you could change to the next slide, please. And just to put some dimension to it, locally in Africa, antimicrobial resistance is claimed to be responsible for about 700,000 deaths annually. And in the next 20 years, it is estimated, based on empirical and modeling data, that there will be about 4 million deaths in Africa annually from some form of antimicrobial resistance or the other. And so AMR, as we call it, is a significant global health threat. And Africa, as usual, is disproportionately affected by this scenario. This slide just shows you graphically what I said. And there in Africa, when you compare Africa to the developed West, Africa and Asia in the next 20 years are going to be suffering significantly from the inability to treat certain kinds of infectious diseases, simply because we've not been able to manage the relationship between infection and treatment, and have allowed these pathogens to develop and mutate and become resistant to our modalities of treatment. So it's a serious problem. Because if in the next 20 years, 4 million people are going to be dying on the continent of Africa from what used to be and could have been treatable diseases, we need to do something very urgently about it. Next slide. And then let me just touch on tuberculosis, because yesterday I spent almost a half of the day with the First Lady, and we were talking about tuberculosis and how we need to disseminate information around tuberculosis, and Lagos being a very high disease-burdened city. We went through an elaborate process of talking, building understanding and awareness, and disseminating and cascading the responsibility to the grassroots level. But we have a big problem with TB in Nigeria. They say almost 10% of death in Nigeria is caused by tuberculosis. For us in Lagos, we estimate to should have 32,000 new cases every year, of which we only find about half. And therefore, there are people walking around with active TB. And they say every single person with tuberculosis will infect 15 more other people every year. So if we have, let's just say we have 10,000 people with active TB in Lagos, in 1 year, those 10,000 people would have infected 15 each, which means that we will now have a total of 150,000 people with active TB. What is a little bit more terrifying is that we're developing resistance in tuberculosis. And so there is moderate drug-resistant TB, and there is extreme drug-resistant tuberculosis. Those of you that know anything about tuberculosis, I think the single thing you will understand about TB is that it's very hard to treat. It's not like a common infection that you take an antibiotic for 7 days and you're done. Tuberculosis takes a combination of 4 antibiotics every day for 6 months to become cured. But if you have drug-resistant TB, and that's the emphasis of this talk, it can take up to 18 months to treat you. And after 18 months, only half of you will ever be cured. And the consequence of not curing drug-resistant TB is twofold. One, as a patient, you will eventually demise. But secondly, before you demise, you may have had the opportunity to spread it to other people. And so drug-resistant TB for us in Lagos is considered to be a pathogen of high consequence. Next slide, please. And when we put tuberculosis into the context of antimicrobial resistance, we can see that there is a large burden component there. 1 in 3 persons that die from antimicrobial resistance are as a result of drug-resistant tuberculosis. Next slide, please. And this slide is very important for policy and government, because normally we see outbreaks or biological shocks coming in waves. And when you are in the middle of a wave, just like COVID or cholera or Ebola, that is not the time to prepare. If you like to create an analogy with security agencies, the Army or the Air Force or the Navy, you don't prepare for war in the middle of war. You prepare for war during peacetime. And so as government, there are certain things we need to do during peacetime. And we're actually busier during peacetime than during war, because during peacetime you need to put a lot of things together when you are anticipating an attack. And in this case, an outbreak of a pathogen is a war on the public health sector. It's a war on the citizens of an environment. And so in between outbreaks, there's a number of things that we must do as government. We must prepare, we must build appropriate infrastructure, we must develop policies and guidelines, we must educate, we must build research capacity, and we must develop the ability to understand the indigenous implications of biological shocks. Just like COVID, we were watching COVID on CNN, BBC, Al Jazeera, and all whatnot. And at the beginning, everybody was using cut and paste. What's happening in Europe? What's happening in America? Let's cut and paste. But what we did in Lagos was unique. We knew we were going to get COVID, and we put together a research team made up of specialists from both Lagos State University Teaching Hospital and Luth. And we decided, as soon as COVID hits, we want to understand the natural history of COVID amongst indigenous people in Lagos. And lo and behold, within the first couple of weeks of the index case arriving in Lagos and spreading to in community, we discovered that COVID was different. It was different amongst Lagosians anyway, and therefore we were able to use that indigenous research to define the policy and strategy on Lagos, and I tell you that it saved us billions of naira, because we would have gone out there and cut and paste and copycat what's happening in Europe, whereas that was not what we needed in Lagos. And so it's very important to build indigenous capacity and research. And in that time, peacetime, you prepare for the next outbreak. And if you're able to do that, then the impact of the next outbreak, whatever it is minimized, and you save lives and you save people from going through severe sickness. But when we're talking about acute shocks, there are acute shocks and there are chronic shocks. So antimicrobial resistance is generally considered to be a slow pathogen, just like HIV. It's not less deadly, but it happens slowly, and it doesn't happen in waves. It's just there all the time. Sometimes you get a little peak, but essentially it's always there. And so those are what we call the slow threats. HIV and antimicrobial resistance are very good examples of slow threats. Next slide, please. And so if you're able to do what you're supposed to do as government, you're able to prepare, you're able to build correct infrastructure, you're able to train, you're able to carry out indigenous relevant research, then the peak of disease in the dotted line will be lowered to what we call flatten the curve. And I'm sorry that this is not projecting, but there's supposed to be a dotted line here. So if you don't do anything as government, you're going to get an impact that goes above your dotted line. But if you're proactive, you can keep your impact below your dotted line. And what is that dotted line? That dotted line represents the threshold of your state's capacity. If your outbreak or your shock exceeds your state's capacity, it will result in significant morbidity and mortality. And so government must always keep a biological shock. It's inevitable, we can't stop it, but you must always keep your morbidity below your government's ability to respond. And that is below the threshold. If you go above the threshold, you will see people dying in the streets. You will see people dying at the gates of your hospitals. You will see massive consequence of sudden biological shocks, which invariably will result in economic downturn and a breakdown of law and order. Next slide, please. So what is happening? Let me cascade down from Africa to Nigeria to Lagos, because that's the way it normally goes. I just came back from the Africa CDC, and that's a wonderful picture of the new edifice called the Africa CDC based in Addis Ababa. And I was there talking about what Africa is planning to do in terms of biological shocks and our ability to use modern technology, such as genomics, just like it's happening in many parts of the world. And the Africa CDC have done significant work in terms of antimicrobial resistance. Next slide. And they've developed a number of frameworks. The Africa Union Antimicrobial Framework, it started in 2017. It's matured up till date. They've done some significant research. Next slide. And the components of the framework are essentially to improve our surveillance, to delay the emergence of antimicrobial resistance in our communities, to limit its ability to be transmitted from one person to another, and to mitigate the harm as a consequence of antimicrobial resistance. And so they've developed a heat map, next slide, for Africa. And I was actually pleasantly surprised when I was looking at this data to see that the antimicrobial national plans across the continent, that Nigeria is actually quite up there in terms of strategic planning. And you can see in dark green, Nigeria, according to the key, has a national AMR action plan being implemented and actively monitored through a monitoring and evaluation framework. Now that's interesting because it shows that there can be a big difference between policy and impact. Because for us in Lagos, and I know for other parts of the world, antimicrobial resistance is running rife. So if us in Nigeria seem to have a very organized antimicrobial action plan, and yet we have a significant burden of antimicrobial resistance, then, well, it means we need to do a lot more work in terms of translating policy and implementing the action points. Next slide, please. Now, one of the components of the framework is called the MAP, M-A-A-P, Mapping Antimicrobial Resistance, Antimicrobial Use, and creating a partnership around how to ensure that we have proper antimicrobial stewardship. And they've done significant research, 819,000 data points from 326 hospitals, 16 national level databases. Significant amount of research has gone into the Africa antimicrobial resistance, antimicrobial use partnership. And there are some key findings. May I have the next slide, please? And for the microbiologists in this room, the data reveals that only 5 out of 15 antimicrobial, antibiotic-resistant priority pathogens selected by the WHO in 14 sub-Saharan countries are being consistently tested. We heard that from the previous speaker, that we're not using microbial resistance testing in our laboratories. The Africa CDC identifies antimicrobial resistance as an urgent public health threat. And then down there in red, it says, based on this MAP report, only 1% of 50,000 medical facilities in the laboratory network of 14 African countries are equipped for bacteriological sensitivity testing and AMR analysis. That is a very serious indictment on the continent. That 1% of our hospitals can even give you a report on sensitivity and the antimicrobial profile of the pathogens that are affecting its citizens. And then it gets worse. The study revealed that only 4 drugs are made up of the 67% of all antibiotics used in our healthcare. What does this mean? It means that our doctors and our healthcare providers don't have enough knowledge and understanding of the diversity of antibiotics that are available in the market, possibly, maybe not available in the environment, but we're only using 4 antibiotics to treat everything. Whereas in the world we have maybe 100, 200 varieties of antibiotics. But in Nigeria, in Africa, everybody is using the same antibiotics. If it's not Ampiclox, it's augmentin. If it's not augmentin, it's Septrin. If it's not Septrin, it's what's the fluoroquinolone? Ciprofloxacin. That's it. We're lazy. We're not understanding that before you treat a bacterial infection, you need to understand the characteristics of that pathogen. And you need to understand the sensitivity of that pathogen, and you need to use the appropriate antibiotic. And so there's a lot of issues around availability, understanding, awareness, infrastructure, laboratory expertise that defines what it is that these pathogens, what type of pathogens are affecting our population. Next slide, please. And so coming down to Nigeria, we have a national action plan, the NAP, on antimicrobial resistance. It ran from 2017 to 2022. I guess it's going through renewal. And let's now come in and focus on Lagos. Next slide. Lagos State, the mega city, the commercial hub of West Africa and Sub-Saharan Africa. The city that won't stop growing. A mega city with numerous mega city challenges. And it's growing by the day. And one of the elements of the pressures in a mega city like Lagos. And let me just say that Lagos is not the only mega city in Africa. Africa is now a continent of mega cities, with rural to urban migration. That is the pattern. That is the result of several issues: climate, bad planning, and other conflict issues. So people are leaving the rural environments and coming into the cities. And Lagos is extremely vulnerable to rural-urban migration. Our population is increasing exponentially, and it's not simply because of fertility rate. It's because people are coming into Lagos for a number of reasons. And this is not a demographic lecture, but just to explain to you that Lagos is under pressure. So Lagos has to think on its feet, because our numbers are increasing, our vulnerability is increasing, our susceptibility is increasing. We cannot afford to be caught with our pants down. And so we have to be proactive and plan ahead. Next slide, please. And so Lagos has a number of strategies. And I'm speaking here specifically about the antimicrobial holistic strategy for Lagos State. We have a policy direction, we have an infrastructure direction, we're working on surveillance, human resources for health, a digital solution, working on research, innovation, and drug management. Next slide. So it is the responsibility of government to preempt and prevent biosecurity threats, to be able to predict what are we doing as a state to understand what the potential threats are, where are they likely to come from. Currently, there are two threats happening on the continent. There is monkeypox and there is Marburg. And just for some clarification, there are two types of monkeypox. There is the local monkeypox and there is the one happening in Central Africa. We're not so concerned about the local monkeypox. We're more concerned about the Central Africa clade 1 monkeypox, which is spreading significantly around the Congo Basin. And now we've heard about Marburg in Rwanda. And guess what? There's a direct flight between Kigali and Lagos State. And somebody could just easily get on a plane and fly into Lagos, just like someone flew into Lagos with Ebola 10 years ago and almost collapsed Lagos' economy. And so we need to be mindful of these things, and governments must be constantly understanding what's going on the continent, what's going on in Nigeria, and what's going on inside Lagos. And so antimicrobial resistance is not something that's necessarily going to fly in, although it can, but we have enough antimicrobial resistance issues internally. And so antimicrobial resistance is an internal threat to our citizens. We need to mitigate, we need to adapt, and we need to be able to respond. And we need to calm our citizens down. And we need to show them that government is being proactive in planning infrastructure, human resources, policies, and strategies. Next slide. Now let me just give you a scenario that happened in Lagos in 2017. A very famous girls' boarding school had an outbreak of what seemed to be a very serious enteritis. In other words, a gastroenteritis. And that's in red. The girls suddenly started getting very sick, extremely sick. They had to be rushed to hospitals. We had to close down the school. Some of them were lost. But what was happening? We sent some samples to some laboratories for deep analysis, and we found out that the water source to that school was heavily contaminated through an admixture with sewage. But why was there in the sewage this plethora of bacteria that were resistant to almost any known pathogen that we have? All these drugs I mentioned, amoxis, augmentin, ampiclox, and fluoroquinolones, they wouldn't touch this kind of infection. We had to import and bring out some very heavy drugs to be able to treat these children, these students. And so the previous speaker alluded to this, that we have to be careful about our water source. We have to be mindful that in a very densely populated demographic profile like Lagos, and Lagos has the heaviest human footprint in sub-Saharan Africa, that our impact on the water table is going to be significant, because human footprint has waste. And when it rains, that footprint percolates down into our water table. So whatever is happening on the surface is reflected in our water table. And that's why His Excellency Mr. Babajide Sanwo-Olu is spending a lot of time and energy on ensuring that we in Lagos can have access to clean water. Water through our massive water purification systems, properly articulated and reticulated to our citizens. It's a massive undertaking, because the groundwater in Lagos is beginning to have some challenges. And we can't keep digging boreholes all over the place. And we must resort to the old-fashioned access to fresh water from some of our big rivers that supply Lagos. And so next slide. In part of our Lagos Biological Shield, next slide please. Forward. We learned this during COVID, that apart from developing the capacity to understand what kind of pathogens we have in our environment, that we're now living in the genomic age. And it was important for us to acquire the ability to genetically sequence pathogens of high consequence. And what we did during COVID, as you know, each wave was caused by a different variant of COVID. And we had to understand what those variants were and where they were coming from, and whether we ourselves were developing variants in Lagos and Nigeria which could be easily exported, thereby contributing to the understanding of COVID across the globe. And so in the next slide, Mr. Governor commissioned what we call the Lagos State Biosecurity Health Infrastructure Projects. And we're looking at this holistically, because managing antimicrobial resistance is not a one solution. It's a holistic problem. There are many facets to antimicrobial resistance. And I'm going to run through a series of projects that are happening in Lagos that are going to give Lagos the ability to be resilient and less vulnerable to antimicrobial resistance through a multi-strategic approach. Next slide. So the first thing is that let us build a facility where we can identify what's going on in Lagos and carry out the appropriate surveillance. And we call that the Lagos Infectious Disease Research Center, or Infectious Disease Hospital in Yaba, mainland. And if you see the next slide, it's a very large place. It is a place that we've notoriously looked after very dangerous pathogens like HIV, drug-resistant tuberculosis, leprosy, Ebola, COVID, cholera, anything that is considered to be a pathogen of high consequence. is admitted to this facility. The doctors here are specifically trained to manage very contagious pathogens that, if they are themselves exposed to, can cause significant sickness, illness, and death. Next slide. And in this facility, after Ebola, we built one of the most sophisticated laboratories in Africa. It's called the Lagos State Biobank. And inside this facility, we have a BSL-2 and a BSL-3 laboratory. So there are 4 types of laboratories: BSL-1, 2, 3, and 4. The BSL-1 laboratory is the common laboratory you see in hospitals that you take a urine sample, you take a swab, and you look for urinary tract infection, you look for sore throat. No big deal. BSL-2 is where you deal with things like HIV and tuberculosis. BSL-3 is where you look after pathogens such as COVID and Ebola. And BSL-4 is where you keep some of the most dangerous pathogens on Earth that are locked away for the safety and security of humanity. Some of these pathogens are natural, but some of them have been engineered. And God help us if any of these engineered pathogens should ever be released into community. Now you might ask, why do we have such facilities around the world? We have them because we're constantly, as scientists and community of scientists, trying to anticipate the mutational ability of these dangerous pathogens to become even more dangerous. And we don't want to be caught napping when Ebola or Marburg or cholera or flu becomes so dangerous that we don't even have any idea of what to use to treat it or how to develop a vaccine. So inside this facility, next slide, we have very sophisticated airflow mechanisms. We also have a genomic sequencer. We have negative pressure ventilation. The people that work in here are not ordinary laboratory scientists. These are specially trained biosecurity scientists, and we have quite a number of them at this facility. Next slide. We've also designed our isolation center. We built a number during COVID. This is the latest version. We've identified the location because we want to be able to have a place that is focused specifically for the admission of patients who have very significant infections. Next slide. And then we're building what we call the Lagos State Infectious Disease Research Institute. We've completed the design with international architects and biosecurity experts. We've broken ground at the IDH hospital, but this facility is so expensive that we're looking for concessional funding, donor funding, to couple with state budget to be able to build a facility that is absolutely necessary for a megacity like Lagos. Because Lagos will forever be under biological shock threat. And we must be ready with an institute like this to collaborate with international partners, with our diasporian colleagues, understanding not only what's going on globally in terms of the external threats, but we must understand what's going on internally. And this is the kind of institution that we must put in place during peacetime so that we're not caught napping during a biological event. Next slide. It is designed ecologically friendly, very nice environment. Next slide. And you can see it has renewable energy solar panels. It's designed in such a way that we can accommodate international partners, consortiums, and do research, constantly understanding what is happening in our environment and constantly being prepared for external shocks from inbound importation of biological threats. Now, next slide is talking about data. We have designed and developed what we call the SHIP, the Lagos State Smart Health Information Platform. It's taken us 4 years to develop the ship. And we put it out to tender, and we've completed the bidding process, and we've awarded it to a concessionaire, and we're about to roll out what we call the ship. Now, the ship is going to be the backbone of Lagos State's response to any biological threat. Because, as you heard from the previous speakers, data is everything. If you don't know what's going on, you cannot respond. And so the Smart Health Information Platform, next slide, is built. Just the next slide, please. It's designed to connect all our hospitals together, all our laboratories in the public health sector as phase 1, and moving into the private sector as phase 2. This will mean that government will have real-time information in terms of what the health-seeking behavior of its citizens are. It will be able to detect trends very early. So if all of a sudden people are going to buy a certain kind of drug in a particular part of Lagos, it will trigger an alert that something is happening in Lagos in a particular location, which will now allow us to respond faster to biological shocks. But it also will make life easier for us. It will help us define policy. It will speed up our ability to manage our patients. Everything will be digital. You won't be moving around with files and letters. If you get referred from one facility to another, your data will follow you. And with your unique identifier, as you go from one center to another, they just pull up your data because it's an information exchange platform. And all that data is going to be held in an archive. And in the backbone and in the background, that data is going to be subject to data informatics analysis using modern machine learning, deep learning, and artificial intelligence. You all know we're in the era of the advancement of data analytics. And what you can do with AI and machine learning is incredible now. And so Lagos should not be left behind. Lagos should have all the health-seeking information around its citizens and their data. We should be able to mine that data, pick up trends, look at what's happening in terms of what kinds of diseases are emerging and evolving, and use that for policy strategy. Next slide. And so the ship is going to look something like this. It's going to connect all our public, I'm sorry it's not projecting very well, but this is basically the ship. And we put the ship to look like a cloud because we're moving into cloud-based technology. And essentially, all our public health facilities, all our laboratories, all our traditional health practitioners. Someone was talking about traditional medicine. We've not left them out because almost 40% of Lagosians go to traditional medicine practitioners before they come to orthodox medicine. And all of that will be captured, including the private sector. And so as government, we will have all the health-seeking behavior in real time being analyzed into trends for policy, for swift action, and for research. Next slide. And now we have Mr. Governor's blueprint for medical digital infrastructure transformation. Medical and digital infrastructure transformation. We keep talking about brain gain and brain drain. One of the things that drives our doctors out of Nigeria is the fact that we don't have infrastructure that is conducive to practicing in a comfortable environment at home. And so for the past 4 years, we've been working on what we call the blueprint for Mr. Governor's transformation. Next slide. And in that blueprint, on the left is what we used to be. We had flawed designs, congested facilities, bad patient experiences, perpetual rehabilitation, bad maintenance, very high energy consumption. But what we decided to do was to shift to the future, and we have developed the blueprint for all our infrastructure now, both primary, secondary, and tertiary. The designs are essentially complete, and we started to build our new blueprint transformation prototypes, and I'll show you a few of them. So what are the characteristics of the blueprint? I don't know if you can see where you are. They are fit for design. They are global standard. They have low energy consumption. They are easy to maintain, and you can repurpose them under certain conditions. Next slide. The attributes are natural lighting and ventilation, a look and feel, a cultural component, sustainable engineering, attention to patient flow, future expansion, rapid pandemic or emergency repurposing, infection prevention control, what we're talking about here, and they are maintenance friendly. Next slide. And so some of the new designs look like this. At the top there is our primary healthcare facility, and below it is the new Massey Children's Hospital. Next slide. And so this is what our PHCs are going to look like into the future. If you look at this design, it has an outer fenestrated wall that allows ventilation through the building. It has a roof and a false roof. And so the PHC is nestled inside a fenestrated building. And on its roof, next slide, is a solar generator able to power this facility off-grid. And we started building 4, and we're just about preparing the land for another 5. In the next 5 to 10 years, all our PHCs around Lagos will look like this. Next slide. The next one is the General Hospital prototype. This was the blueprint prototype. And from that prototype, next slide, we've developed the new Massey Children's Specialist Hospital. And if you drive anywhere on Osborne Road, from Ikoyi onto 3rd Mainland, just look onto your left, or if you're coming from mainland, look onto your right, you'll see this massive edifice rising out of the ground. And that is the first General Hospital blueprint prototype of our new designs, fit for purpose, low energy, sustainably engineered, attention to infection prevention control, patient flow. The next prototype, next slide, is the Shomolu General Hospital. So we're about to demolish the whole Shomolu General Hospital, and we're about to break ground and start this building. Next slide, please. Now, we talk about drugs. Lagos is about to develop its drug management agency. It's critically important that we as government are able to monitor the quality of the drugs available to our citizens in Lagos. Because after you go through your first quality assurance, the subsequent batches brought in by certain unscrupulous drug dealers may not have the same quality as the ones that were submitted for quality assurance. And so we have antibiotics circulating in Lagos that have 20, 40, 60, 70% active component instead of 99% active component. And that drives antibiotic resistance across because you're treating infections with substandard medications. And so the architecture of the Drug Management Agency, next slide, is to ensure that a partnership with private sector, we can establish a pathway for ensuring that every drug available to Lagosians is going through continuous quality assurance and monitoring, and that we're able to stabilize the prices through economies of scale and continuous drug quality assurance monitoring. Next slide. Now, one of the problems with antimicrobial resistance is the concept of task shifting. Because we have so few medical professionals left in Nigeria and it's beginning to affect Lagos, because people drain from Nigeria into Lagos, and from Lagos they drain out of the country. And so we have a reduced number of medical professionals to look after our citizens. And so Mr. Governor decided that enough is enough. We can't keep talking about brain drain perpetually. We've got to do something about it. Now, apart from the brain gain strategy, which we are adopting, we're making sure that anybody that wants to come back home, you just let us know. We'll find out how we can assist you. We'll find out how we can fit you into the master health strategy for Lagos, either in the public or in the private or in the hybrid PPP facilities that we're developing. But when it comes to producing medical professionals, we, next slide, have a problem because we're only producing 100 in our state teaching hospital and another 100 or so in the federal teaching hospital. So that means that Lagos produces about 200 doctors every year. And if you interview those doctors, 80 to 90% of them, their mind is somewhere else. They have already jackpot. They may be physically here, but they have gone. And so if 50% of them leave, it means we're left with 100 new doctors every year for a population of 30 million people. The World Health Standard says that we should have one doctor for 600,000, for 600 people. We have one doctor for 4,000 people. And I'm using doctors as a surrogate marker. No intention. They're nurses, just as important. They're scientists. They're laboratorians, they're physiologists, physiotherapists, they're all important. But we have a significant deficit in human resources for health in Lagos. And one of the reasons is we have confined our training to our teaching hospitals, our tertiary academic centers, LASUTH and LUTH. So what we're going to do in Lagos State is we have significant asset. We have about 30 general hospitals. Some of them are almost as big as the teaching hospitals. 30 general hospitals and about 60 flagship primary healthcare facilities. These are these big PHCs with about 5 doctors and 15 medical staff. What we're going to do is we're going to cascade our training from our teaching hospitals into our general hospitals and into some of our PHCs. Because doctors and health professionals are not trained in lecture rooms. They're trained as apprentices. And all you need is a patient to transfer knowledge from a lecturer to a student. And in our general hospitals, we see 7 million patient contacts every year. 7 million patients. That's enough patients to train 5,000 doctors. But we're training 100. And so Mr. Governor said, build a standalone University of Medicine and incorporate the assets that we have as Lagos State into your group of teaching hospitals. Next slide. And so what we've done is we've divided Lagos into 5 Ibile zones. And there are general hospitals scattered across our Ibile zones, and we've clustered them. And so the new University of Medicine and Health Sciences is going to be a multi-campus university using our incredible medical assets in Lagos, 30 general hospitals and over 300 primary healthcare facilities, to now start training thousands of doctors and nurses in Lagos to pour more resources into our human resource pool. Next slide. And so it's going to look something like this. We're going to admit over the next 3 years, we're going to take our numbers up from 100 to 1,000 medical students, from 50 nurses to 1,000 nurses, 500 allied professionals, pharmacists and dentists. And so in about 3 or 4 years, Lagos is going to be producing thousands of medical professionals. And if 50% of them want to jackpot, so be it. Because guess what? When you jackpot, you send money back home, which goes into our economy. Number one. Number two, you don't jackpot forever. Many people in this room have jackpot and have come back. And guess what? We're enjoying the benefit of millions of dollars of expertise training. I jackpot 3 times. This is my 4th return. And I think it's too late for me to jackpot again. But there are many people in this room that have jackpot and are back. And when you come back, you go out of the country with a basic medical degree and you come back with 3 or 4 degrees in specialties of medicine, in subspecialties, and we get that free of charge. So Mr. Governor is not worried about jackpot at all. His strategy is, we have the youth bulge. We have the intellectual capacity. If the rest of the world want to take our youth bulge, fine, you can't take all of them. You can take some. And I tell you, I've spent a lot of time around the world. There's something Nigerians do on Sunday. They get together, wherever you are, South Africa, England, America, they get together and they eat eba or pounded yam or whatever. The one conversation, the single one conversation is, I wish I was back home. I don't know many Nigerians that don't want to come back home. And so all we have to do is create the environment for our Nigerians to come back home so that they can practice in an environment that they are accustomed to and to be appreciated. And there are many things we're doing in Lagos. I don't have time to talk about that. There are many things we're doing in Lagos to create that enabling environment for our diasporian specialists to come back home. All right, I've almost finished, Dr. 10 more minutes? 5, okay. Next slide. Let me go back to some nitty-gritty. I think Dr. Folake talked about this. You know, there's a lot of education we need to do in Nigeria and in Lagos. You present with a febrile illness. Maybe 1 out of 10 fevers is malaria. So what's the remaining 9? Nobody is spending any time whatsoever to find out what is causing your fever. What you get is an anti-malaria and an antibiotic, standard treatment. It's called polypharmacy. It is dangerous. Not only is it dangerous to the individual, it is dangerous to the ecosystem. And it breeds antimicrobial resistance that is going to come back to affect us. And so that slide there says, get well soon. It's not every patient with a fever that needs to be treated. In fact, most people do not need anything other than simple Panadol. But what happens? Patients, and it's a double problem. The patients will present to you as doctors, or nurses, or pharmacists, and they will tell you what is wrong with them. They will tell you, I have malaria. Now, malaria is not a symptom. Malaria is a disease. They should tell you, I have fever, I have headache, I have body pain, I have bitter mouth, I'm passing a lot of urine, I have a sore throat, my nose is blocked, my ear is hurting me. Fine. Then the doctor now or the nurse needs to take a proper history and a proper examination and decide whether you have the features of malaria or something else. And then do an appropriate test. And if you're malaria positive, you should have anti-malaria. But you should have anti-malaria through your mouth, not by injection. Is there something wrong with your mouth? No. Why would you choose an injection, which comes with its own complications? First of all, when you inject something into the body, you can't take it back. And secondly, you can get an infection, you can get an abscess. But our citizens insist they have malaria and insist they want an injection. So we need to carry out a lot of behavioral change amongst the citizenry. And guess what? The doctors listen to the patients because they want to be paid. Because if you tell your doctor, oh, go home and get your patient, go home and get well soon, there's nothing wrong with you. You have a mild viral illness that is self-limiting. You will get well without any intervention. They say, this doctor doesn't know what he's talking about. And they will leave your practice, and they will go to the next practice and say, yeah, doctor, I hope that you are better trained. Please, I need my injection. So, see how much work we have to do? There is no amount of antibiotic that's going to treat a viral illness. You can give them every antibiotic you like. It's not going to work. A virus is a virus. It is not susceptible to antibiotics. Similarly, malaria. Why would you treat a malaria patient with an antibiotic? So we've decided in Lagos, next slide, to carry out some research with the WHO. And we're looking at the Nigerian Malaria Elimination Program and Pharmacy Council of Nigeria and an NGO called Maisha. We actually want to understand what is the burden of malaria in Lagos, the true burden, and we're getting funding from the World Bank for this research. We want to understand how many times if you have a fever, 100 patients present with fever, how many of those fevers are malaria? And if they are not malaria, what are they? And what is the correct algorithm of treatment? Because that's the only way to stop antimicrobial resistance. First of all, to find out what the problem is and to give the correct treatment that will deal with the problem in the right doses and the right quality. And so we have malaria positive, we have malaria negative, monotherapy, and oral treatment. So we're developing policies. We have a bioeconomy governing council. We're drafting our biosecurity bill, which includes antimicrobial resistance. We have the Emergency Operations Center, and we have something called the Incident Command Structure, which is what Mr. Governor is in charge of. Next slide, please. Yeah, next slide. And we're developing what's called LASMISO, which is a proposal for Lagos State to develop medical industry and innovation. We're going to go into the Lagos Trade-Free Zone. We're going to identify areas there where we can attract companies that want to come and manufacture drugs, that want to come and do bioequivalence testing, that want to come and develop the infrastructure that is required for vaccine development, want to build multi-specialist hospitals filled up with diasporians. So that is the LASMISO project. We are at the beginning of conceptualizing that at the moment. Next slide. And it will have a variety of buildings that look like this. Modern buildings where we can do modern research, where we can do modern innovation pipelines with our digital infrastructure, the ship, with our new buildings, with our ability to train more personnel, with our ability to attract our diasporians home, with the amazing expertise that they have. Lagos is poised to become the center of medical excellence in sub-Saharan Africa. As I finish my presentation, next slide, what do we need to be wary of in the future? There's something that's happening globally. Next slide. It's called synthetic biology. And because we've been able to unravel the genetic code of humanity and the ecosystem around us, we're able to, next slide, we're able to tinker around not only with ourselves, but with the ecosystem around us. So if you go to America, everything you eat is genetically modified. Cows are cloned. The whole environment is under the jurisdiction of genetic manipulation. And so, next slide. We, in Africa, we need to be wary of this. But we also have to catch up. Otherwise, we ourselves will not be able to understand what is coming into Africa. And so we need to develop, next slide, synthetic biology capabilities on the continent of Africa in Lagos and Nigeria. Because people are beginning to manufacture pathogens. Not every pathogen now is natural. We have the capacity to tinker around with the genetics of everything, including yourselves. We can clone animals. We can tinker around with crops. We can change pathogens. As I said, we keep dangerously changed pathogens in biosafety level 4 laboratories around the world. These are pathogens that have been made to be more virulent. Next slide. It's called gain of function research of concern. So there's pathogens of high consequence, and there's gain of function research of concern. Scientists around the world are tinkering around with dangerous pathogens and making them even more dangerous and resistant to any kind of intervention. They need to do this, according to them, because if you allow nature to do it itself, it will spring a surprise on you. And therefore, you need to have the understanding of what these pathogens are going to look like when they naturally develop their mutations. And you need to be able to have drugs and vaccines that will protect humanity. Next slide. But what's the problem? This doesn't project at all. I apologize, but this is supposed to be Africa here. And there is almost zero activity on the continent of Africa when it comes to the ability to manipulate the genetics of the ecosystem. So in conclusion, next slide. AMR poses a significant threat to public health and development in Africa, but comprehensive, coordinated, and sustained efforts can mitigate this impact. The African Union, Nigeria, and Lagos State are taking important steps, but further action is needed to build resilient healthcare systems, promote good stewardship and appropriate antimicrobial use, and safeguard the health of our citizens. My final slide. Lagos is acutely aware of the threats. We understand our vulnerability. We understand our challenges. We have limited resources, but we're making the best of what we have, and we're making sure we collaborate. And we're very, very keen to attract our diasporians home to come and help build a more resilient Lagos State. And Mr. Governor always says, keep on communicating. Thank you very much.
Wow. What did I say? I said, it's not everybody that is privileged to know firsthand, what Lagos State is planning for now and for the future. Professor Abayomi has done that for us, so you know what to expect from Lagos State. We appreciate it very much. Your knowledge, of subjects is tremendous, and we appreciate it. We say thank you very much, for the time you spent here, and you're still sitting down to listen to the other lecturers. No, it's a thing of privilege, and we don't take it for granted. Thank you very much. Thank you. The next speaker is Dinitab. She's a pharmacist. She actually works in my hospital in Columbus, Georgia. She's the clinical pharmacist there. She's well organized. She was a microbiologist before she went to infectious disease pharmacy. She's going to be talking to us about MDR-gram-negative organisms, the impact of clinical microbiology on antibiotic selection.
Okay, good morning, Dr. O, and all of those that are attending. I'm going to go over the impact of clinical microbiology on antibiotic selection. The objectives of this talk are to demonstrate the clinical impact of microbiology tests on gram-negative infections. I'll highlight some microbiology workflow as it relates to positive blood cultures. And then I'll introduce some microbiology regulatory requirements for documentation of in vitro sensitivities that we do in laboratory. And then if we run out of time, there's some standalone slides that go over some different anti-infectives, including spectrum activity and dosing for multi-drug resistant gram-negatives. So I want to start out with case 1, which is a 73-year-old male found unresponsive, admitted for sepsis and neutropenia. Note that he is on active chemo with a port in place. We initiated empiric cefepime and vancomycin whenever he came in with sepsis. And within 12 hours, his blood cultures were positive for gram-negative rods in all 4 bottles. 2 organisms were identified by our film array panel, both E. coli and Klebsiella. And note that the CTXM positive gene was also identified. The patient was switched to meropenem. So from our workflow status in microbiology, the first thing that we do whenever these bottles come off of the BacT-Alert instrument is we perform a gram stain, we aliquot on some plates, and then we also call the panic value to the patient's location. If it's a gram-negative rod or gram-positive cocci, we take an aliquot of that sample and we place it on the film array panel. Now, the film array panel actually takes about an hour and 15 minutes for it to complete. And then it actually falls into this best practice bucket that's in EPIC. Now, the EPIC best practice bucket here at the hospital is manned by first shift and second shift clinical pharmacists. So if there is a disconnect in empiric therapy that the patient is on, and what the BacT-Alert gives us as far as appropriate treatment, then that pharmacist will reach out to the provider at that point for alternative treatment. Note that the gram-positive rods, both in the aerobic and anaerobic side, are not included in the BCID, and that's because the antigens are not included, or the genes are not included for these particular organisms. So what do we do after hours on third shift to assist our ER providers? We have an internal antibiotic stewardship website on our intranet, and we have this clinical pathway that really gives them a little bit of information about, the gram stain morphology, and if it's important to wait to the next day or to get the patient up in the wee hours of the morning. So if we look at the previous case, gram-negative rods may be life-threatening, and we're really recommending that ER provider call the patient in immediately, and that could be at 2 a.m. in the morning, but it is life-threatening or can be life-threatening, and so the providers will call them in. For Enterobacterales CTXM positive, it also tells them to initiate meropenem the minute that they come in the door. Back to our case 1, here is the phenotypic susceptibilities for both the Klebsiella and the E. coli, and you can appreciate that it's the E. coli that is ceftriaxone resistant. We're using ceftriaxone as a proxy for ESBL. Note that in our hospital, we actually add this additional comment to all of our ceftriaxone resistant Enterobacterales that states isolate is most likely an ESBL, and carbapenems are a more reliable treatment. So CTXM enzymes are the most common ESBLs in the United States, but we do have some TIM and Sheave, 8.6% and 1.2% respectively. prevalence of ESBLs can vary geographically. If you look at the top left-hand corner, this is a Kirby-Bauer ESBL confirmatory test. And you can appreciate that this is very labor intensive. We did this for many years on the bench. It also increases turnaround time for sensitivities for the patient by 24 hours because this requires an additional 18 to 24-hour incubation. So Microscan, which are the panels below that, actually reinvented this ESBL screening and confirmatory into the microbroth wells. The only thing that we found to be an issue is the Microscan panels overcall ESBLs. So why is it important for us to be able to identify ESBLs with good sensitivity and specificity? 2001, a study identified that patients that were treated with cephalosporins and had confirmed ESBL, 54% of those patients experienced clinical failure. So in 2010, CLSI dropped the cephalosporins and acetrinum breakpoint. Note that ceftriaxone went from less than or equal to 8 to less than or equal to 2 micrograms per ml here. And in 2000, an update in 2000 after that, cefepime was actually reduced from less than or equal to 8 to less than or equal to 2 micrograms per ml, and a sensitive dose-dependent strategy of cefepime 2 grams infused over 3 hours, Q8, was also introduced. In 2011, post-implementation of the CLSI breakpoints for the cephalosporins, this study wanted to validate and make sure that ceftriaxone was a good proxy, and all 382 strains that were confirmed ESBL, they were all resistant to ceftriaxone, and therefore that is the reason why we use that as a proxy. In 2017, even the drop in the breakpoints for cefepime were called into question as far as the clinical utility of cefepime, and it comes from the clinical failures where they use the higher doses of cefepime for ESBL. So we actually do not use cefepime even at its higher dose for ESBL infections here at our institution. We're going to move on to case 2. 75-year-old male presents to the ED for evaluation of abdominal pain and emesis. He was diagnosed with sepsis from abdominal stores, and he was started on broad-spectrum piperacillin and tazobactam. Note that the film array came back positive for E. coli, and CTXM was not identified. Within 36 hours, the susceptibilities were available, and you can appreciate that this isolate is an ESBL, and it is ceftriaxone resistant, and so Zosyn was switched to meropenem. The sensitivities here are all in alphabetical order. I want you to notice here that we don't actually report out piperacillin and tazobactam whenever it's sensitive. We choose to only report it out for ESBL bacteremias if it is resistant. If it is sensitive, our institution decided to suppress it based off of the Marino trial. A lot of you are familiar with the Marino trial. It was a randomized non-inferiority international parallel trial. They used intermittent high-dose piperacillin and tazobactam and also meropenem in the alternative arm. 378 patients were enrolled in this study. Primary and secondary outcomes are listed. The study was stopped early due to a threefold higher 30-day mortality. For sake of completeness, I included the Marino 2 trial, but note that the organisms that they focused on at this point with the same infusion strategies were AMP-C-beta-lactamase producers. The study was terminated due to slow accrual. So how do we keep up with this information in the hospital setting? And this is applicable to any hospital. CLSI recently released tier criteria, so tier 1, 2, 3, and 4. We actually went through all of our organisms and and categorized each of our antibiotics into these tier criteria. Tier 1 automatically crosses the interface. Tier 2 and 3 are cascade reporting based off of criteria. The other thing for regulatory purposes that we have to keep up with is what breakpoint are we using and in what situations. So CLSI breakpoints are to the left, and then there's the center column, which is FDA interpreted breakpoints. And then what is your instrument, breakpoints concurrent with? Is it FDA or CLSI? Sometimes you have concordant all the way across, and other times you have discordance. If you have discordance, you actually have to validate what you are choosing to use for your breakpoint, whether it's CLSI or FDA. And then sometimes you may even have to validate reflexing to an e-test for additional MICs. So ESBL treatment not only includes the carbapenems, but if you have maybe a ESBL UTI, fluoroquinolones and trimsulfa can be dependable in those scenarios. Case 3 is a 79-year-old female, hospitalization day 25. She had a new onset sepsis. She had an infected sacral wound, and that was the suspected source of her sepsis. Rocephin and Zosyn exposure led to meropenem and vancomycin being initiated empirically, and then her BCID came back positive for Acinetobacter baumannii complex. Her meropenem was empirically switched to 27 grams of Unison per day and high-dose minocycline. The sensitivities of both Acinetobacter from the skin soft tissue infection and the bloodstream are pretty much concordant here. Note that the ampicillin sulbactam is intermediate with a sulbactam MIC of 8 micrograms per ml. Now that high dose 27 grams of Unison per day actually will theoretically cover all the way up to 32 micrograms per ml of your sulbactam. This year, IDSA updated its CRAB treatment. That can be found in this guideline, and you can see that currently we're following the alternative strategy. We do have some e-test strips coming in for ampicillin sulbactam, the Unison, and that's because our panels do not identify and go up to 16 and 32. We also have some e-test strips coming in for sulbactam, durlobactam. Internal data for our Acinetobacters for 2023 is listed here. We identified 73 patients out of that year, and of those, 17 were non-Baumannii complex. All of the Acinetobacter non-Baumannii were susceptible to meropenem. The Baumannii, however, only 66% were susceptible to meropenem. We had an additional 32% that were susceptible to cefidorocol, and we had one isolate that was resistant to cefidorocol. We actually make our antibiogram available on our intranet as well, so everybody has a different format for their antibiogram. But you can see the Acinetobacter here is at 75% susceptibility to Unison, and meropenem is at 69%. Your Unison does not include those MICs that are sulbactam of 8, 16, and 32, so likely much higher here. When we look at our cascade reporting, our old reporting guidelines included all the antibiotics on your left-hand side would cross the interface for Acinetobacter, and now post-implementation of our tier criteria, the routine reporting is in the center column. Those cross the interface, and then there are conditional reporting with the rules below for the additional anti-infectives on the right-hand side. Now I'm going to go into a few of antibiotics. If we run out of time, then these are standalone documents that you'll be able to review these slides at a later date. Sulbactam, durlobactam is a prolonged infusion, 3-hour infusion strategy. It does cover crab very well. FDA-approved indications are HAP and VAP. Notice the 28-day all-cause mortality and clinical cure, the nephrotoxicity being higher in the colistin arm. For cefiderocol, it does cover crab, but also multi-drug resistant pseudomonases, which we have used it for in the past. FDA approved for HAP and VAP. This is also a prolonged 3-hour infusion strategy. A really nice article identified, what do we do in these, times when, cefiderocol is resistant. They are actually exploring different inhibitors attached to cefiderocol. And you can see that in a lot of these cases, it reinitiates susceptibility to greater than 90%. And then your sulbactam, durlobactam in this scenario of cefiderocol resistant crab is at 72%. Antibiotics for KPC, with Klebsiella pneumoniae being the most common KPC producer in the United States, are listed here. How did we identify our KPC in the past? If you look on the left-hand side, we did the modified SIM, and you can appreciate that this is very tech intensive.
Didi, sorry, one second, okay? You know what? Look, most of the people here, most of them are not doctors, So, most of them are sleeping already. So, Didi, just round it up so that, your slides are in there. I will share with the doctors, that are going to come, okay? So just because there are some other speakers that has to speak, in the next 30 minutes, okay? So please just round it up. Thank you.
Okay, will do. This is our new technology, the Cepheid. Abicaz spectrum of activity is listed here, along with its dosing strategies. Vabamere is listed here. We haven't had the need for Ricarbrio just yet, but certainly it has activity against KPC and Enterococcus faecalis. New Delhi, beta-lactamase. Treatment is listed here. The ceftazidime avibactam plus azathioprine is what we would use in this scenario, and it is superior to non-beta-lactam treatments. And then this product, azathioprine avibactam, has been recently approved in Europe, and we look forward to having it available here in the United States. Oxy-48 light producing treatment is listed here, and then your last antibiotic, the cefepime taniborbactam, it's going into clinical trials October 2024, which is this month. And then I'm going to leave you with this summary slide that just tells you the select antibiotics and its activity against carbapenem-resistant organisms. So this is a nice summary slide. And now I'm open for any questions that anybody may have.
Oh, thank you very much, Didi. That was wonderful. Yeah, very much.
You're welcome.
Look, your slides are fantastic, and I'm sure there's a lot of information there. They can always read up on their own. Does anybody have any question for Didi before she goes, because she has to work? Does anybody have any questions? Nobody has any question.
All right, thank you.
Thank you, Didi. I appreciate you. Well, I'm so sorry, I'm not a very short person. I don't call people short, but I don't want to lose your attention, okay? And Dr. Sheyo Ishola, who is a friend that I've known since my childhood, who has practiced medicine, both in Nigeria, the UK, and she jumped back to Nigeria after many years in England. He specializes in critical care and anesthesia. He's just going to talk to us for 20 minutes on critical care, infection in the critical care units, secondary to multi-drug resistant organisms. Sheyo Ishola, if you don't know him, is a man of high repute in the critical care in Lagos, Nigeria. Thank you.
Thank you. This one is not mine. No. Does this not look like the middle of the... Oh, thank you. The very first slide, please. So good afternoon, everyone. It always worries me when the specialists in any area ask a non-specialist like me to come and give a talk. So I know it's a booby trap, but it's all right, Dr. Oluboale. We will cope with that when the time comes. I'll start with a very quick story of what happened when I came back the very first time. And I had to work in an intensive care unit, and the choice of antibiotic I was given to use on a septic patient was meropenem. That was the first antibiotic choice. I didn't quite know how to respond because a very senior person made that recommendation. And we were all, good morning, sir, good afternoon, sir, 3 bags full, sir, to this consultant. But the very first choice was meropenem. So I tried to be diplomatic. I took the gentleman aside and said, please, let's just talk about this antibiotic privately. He said, no, there was nothing to discuss. Let's just start the meropenem now. The patient is very sick. I said, well, okay, sir, if that's how you want to go, but can we just take a number of samples? The way I was trained in intensive care, we'll do blood, urine, sputum, at the very minimum, and send that off before we start antibiotic therapy, so that in the process, if we need to change, we'd at least have got a few days in, and we wouldn't have the complication of the antibiotics on board. And he said, look, Dr. Eshola, I understand you are recently returned from wherever it is you come from, but this is not how we do things here. We start with the heavy, big guns, and then we de-escalate. I mean, how many people in the room recognize that approach? Am I out of order? Or does that still happen? No? In any case, the problem is this. If we are antibiotic prescribers, users, and we do not take the time to look at the consequences of the antibiotics we prescribe, how we prescribe them, and monitor their effects, I think we are not going to be able to understand why or how we get to where we are. Can I just ask a quick question by a quick raising of your hands? If you understand culture and sensitivity tests, I think the concept is actually so simple that whether you're a doctor or not, it's important that you understand this for the future when you actually go and you either get prescribed antibiotics that haven't worked, you've been on them for a week or 2, and the antibiotics don't seem to be making you feel better. Can you just, by show of hands, tell me how many people in the room understand the concept of culture and sensitivity? Okay, that's still quite good, because I know it's less than a quarter of the room, and it's important for me, I think, to try and describe what culture and sensitivity means. In modern medicine, if there is an infection going on, and we are reasonably sure of the source, and even if we are not, we take a number of samples, body fluids, urine, it may even be blood, maybe stool. The important thing is to take this body fluids, take a small sample, send it to the lab. What culture and sensitivity does is to use a small sample of that to grow the bacteria. Then we now have specific antibiotic tablets. They are tiny little bits that we spread around where the bacteria are expected to grow. If we observe that the antibiotic tablets on that little growth dish kills the bacteria, we say that that bacterium or that group of bacteria are sensitive. And this is the cornerstone of the work we do, especially in intensive care. Am I making any sense? Okay. So once we've got a positive result, in other words, the bacteria appears to be sensitive to the antibiotic, then we proceed to change, if we're already giving a different one, continue if it is the correct one, or add if as the need arises. So next slide, please. I think the information on this slide has been covered by previous speakers. It just generally introduces the concept of antibiotic resistance. Next slide, please. And this one too, Professor Abayomi and another speaker has covered the statistics. So I won't take any more time. It just goes to emphasize just how serious the problem is. Carry on. Now, if 60% of ICU infections involve, and I'm talking 60%, 6 out of 10 of bacterial infections involve, these are the bacterial infections in intensive care units. If they involve multi-drug resistant organisms, and I'm going to show you 3 different multi-drug resistant organism results that have actually happened in the last 1 month on the patients that we've treated. So you get a sense of how common and how important this is. If we get 60% of such cases in Nigeria, and I think in my opinion it's a bit more, but once you see these lab results, you'll see what I mean. Next slide, please. Yes, once again, this has been covered. I think we've talked about the different species that are resistant, and we've talked about the different mechanisms of resistance. And Klebsiella, Pseudomonas, those are the big ones. Next slide, please. So we start with empirical therapy. Empirical meaning that we don't know exactly what this organism is sensitive to, but we have a guess based on experience. So we give it. We start giving the antibiotic. After a while, we change. Whatever happens, because there are no what they call antibiograms, we don't have sufficient technology to do the testing. We continue to give empirical. And it just delays, prolongs hospital stay, and some patients actually die. By the time you get to ICU, you've passed the general practitioner, you've passed the doctor on the ward, and invariably you've passed somebody who thinks, oh my goodness, if we don't do something now, this patient is going to die. The last patient we received at a hospital that we provide intensive care for came from Birling Kebbi. You guys know where Birling Kebbi is? Somewhere far up north. Indian patient. Came in, was asked to come and do some installation, started his installation and became jaundiced. He had developed a cough with pneumonia, had difficulty breathing. He stopped passing urine. In short, he was in multi-organ failure. So he had evidence of sepsis, which they thought might have been meningitis, and of course, maybe malaria. But in his case, it was well-founded in the sense that malaria in the non-immune can be a real problem. What antibiotics did we use? Piperacillin, tazobactam, the famous piptazo, which I'm sure you've seen on several slides. Did it work? We don't know. The guy died 3 days later. Unfortunately, this is one of those situations where time is not on our side. I will end the presentation here and I'll take any questions if there are any real pressing issues. Otherwise, I will have to go.
Well, thank you very much, Dr. Sheyi. That was short and nice. So we only have one more speaker. The next speaker, who's going to be speaking very briefly, is going to be Dr. Bolaji Ogushaki. He resides in Macon, Georgia. He's an infectious disease specialist like myself. He's participated in multiple episodes of both here in Nigeria and America. He's a very good friend of mine, a very good friend of my friend who also came with me, Dr. Barry Osman, who's a nephrologist. He's sitting down there. But like Buri J, please get up to be recognized. That's my best friend. But like, thank you. Balaji, you are so welcome. Look, everybody's looking at me. Everybody's tired already, so please make it very short for us, please, okay? I appreciate you very much, your time. I know you prepared a lot for this, but your slides, I mean, it's on the brochure. They can always review it, okay? Thank you very much. Let's go.
Can you project my slides? Enlarge them, please. Very good. Excellent. Good afternoon, everybody. Good afternoon, Honorable Commissioner, colleagues, ladies and gentlemen. It's my honor and privilege to participate again this year. Again this year, I'm one of the last to present, and time is of essence. So I will try and summarize everything in a very short period of time. I thought that I was going to have to, next slide, I thought I was going to have to explain why I picked my topic. But fortunately, Professor Abayomi has alluded to some of what I'm going to talk about. So he has served as a bridge onto my own presentation. My colleagues have talked a lot about evolving resistance patterns in gram-negative bacteria, which is a global problem. So I'm not even going to talk about that. Next slide, please. So there is a need for, like Professor Abayomi said, there's a need for a national security policy against man-made external attacks. The COVID-19 pandemic taught us to prepare against pandemics arising from emerging novel viral pathogens. So most nations now have in place a national security policy for protection against man-made external attack like war. However, most nations do not have a national health security policy in case of a natural pathogen or a weaponized man-made bioterrorist attack. Next slide, please. Professor Abayomi alluded to this fact that in the world, in some countries of the world, there are highly resistant weaponized bacteria that have been produced and stored for various reasons, for research, but it is clear that some of these can be used as agents of offense in times of war. And then this can lead to future pandemics. So we need to think about the possibility of a gram-negative bacteria pandemic in the future. It happened in the past. If we look into history, the Black Death was a pneumonic plague pandemic that occurred in Europe from 1346 to 1353. It killed 50 million people, 50% of Europe's population. It was caused by Yersinia pestis, a gram-negative Coccobacillus. Now, this bacteria has been weaponized by some countries and is a prime candidate for present-day man-made bioweapon causing a pandemic. Next slide, please. So we need to prepare against this possibility, and we can use the COVID-19 blueprint. I won't go over this in detail, but we have a blueprint that we can modify and tweak to use against gram-negative pandemics. The WHO is playing a major role in strengthening global health security interface in this respect. Next slide, please. So, concern about resistant gram-negative bacteria as bioterrorism agents. Since the 2001 anthrax attacks in New York City, I was in New York at that time, there's concern growing about the use of weaponized bacteria to attack institutions or countries. So what's the concept of weaponization? And that the concept is to make the bacteria more infectious and to make them more resistant to antibiotics. Potential candidates in this regard include Francisella tularensis, causative agent of tularemia, Yersinia pestis, causative agent of pneumonic plague. Next slide, please. So tularemia is a bioweapon. I'm not going to go into all the stuff that's on here, but suffice it to say that in the 70s and 80s, the Soviet Union conducted focused research into making this organism a multi-drug resistant strain. So they have already developed this. They have this in storage to use whenever they want to. It can easily be stored in the dried form. It can cause life-threatening infection by inhalation. It's been engineered to be antibiotic resistant. That's a gram-negative pathogen. So even though the use of biological weapons was prohibited by an international treaty signed in 1972, the threat of bioterrorism persists till today. Next slide, please. So I won't go over this. This has been touched on by some of my colleagues. Next slide, please. And most of this has already been touched on. I was quite thrilled by the presenter before the last one. She did a great job presenting all the antibiograms and the latest antibiotics. But then I remembered Professor Abayomi saying that most of the time there are only 4 antibiotics that are being used in Nigeria and in other West African countries, only 4. So we don't have access right now to all those newly developed beta-lactam, beta-lactamase combinations and carbapenems and other things. We don't have access to that. Next slide, please. So the most important thing about an organism being used as a bioterror weapon or being weaponized is the ease of dissemination, whether by water, food, or in aerosolized forms. Whenever the bacteria has been modified to make it easy to spread in such means, then it's a bioweapon. So a small dose of the bacterium is required to cause an infection, which means a small quantity of bacteria can infect a large number of people. Aerosolized Yersinia pestis has this ability when it causes pneumonic plague, and it can be transmitted from person to person, which means it has pandemic potential. Next slide, please. So high infectivity and mortality rates, we've already talked about that. Yersinia pestis is very infectious. It causes 100% mortality within 24 hours if it's not treated as pneumonic plague. So it's very important to determine early in the course of the outbreak what infection is capable of airborne spread or not. It's also very important to correctly diagnose what the organism is, which means we have to have an effective lab system. Next slide, please. National Public Health Systems pandemic preparedness details. Very, very, very important. We have to prepare and to mitigate risks associated with infections caused by resistant gram-negative bacteria. Some of these things have been alluded to before, so I won't go over this in detail. Next slide, please. So countermeasures have been talked about in some ways. Development of strategies to combat antibiotic resistance, development of new antibiotics, rapid development and deployment of vaccines, international healthcare collaboration between nations. Next slide, please. This is an urgent public health problem, as alluded to by Professor Abayomi. And some of the reasons why this problem is prevalent and spreading, we've talked about antibiotic use and misuse. We've talked about lack of control of prescription of antibiotics. We've talked about, one thing that we didn't talk about was the use of antibiotics as growth promoters in food animal production industry. In many countries of the world, antibiotics are added to the food of chickens and cows and goats to make them resistant to infections and make them grow bigger. So in that way, the bacteria are exposed to these antibiotics, and that is actually a major cause of VRE in the world. Next slide, please. So these are some of the references, but the points I want to drive home are, number one, this is a problem that is not due to legal use of antibiotics. Developing resistant pathogens for bioterrorism is something that is intentionally done by people in some parts of the world to harm other people. You know, bioterrorist weapons are designed specifically to harm people. So this is a paradigm shift in the thinking about resistant gram-negative bacilli. There are so many local and global conflicts going on right now, and some of the countries that are involved in these conflicts already have production of resistant gram-negatives as agents of bioterrorism. Even in Africa, in our next door neighbor, there's a struggle going on between some major powers of the world and the government, the national government. It is not inconceivable that they could deploy gram-negative bacteria like Yersinia pestis as an agent of bioterrorism by aerosolization in our next door neighbor. And of course, you know that it will spread to Nigeria. So I was very happy to listen to Professor Abayomi's presentation. He gave us a lot of hope for the future. He gave us hope that there's a lot of thoughts going into all these issues, and there's a lot of planning going on. And it makes one feel like Jackpine back. Thank you very much.
Thank you very much, Dr. Bolaji Ogushaki. That was good, you know, so we all need to be very careful. And quite interesting, we come to the end of the program, but the next 15 minutes, we can take questions. That's going to be very brief, so that whatever is not clear to you from the presentation, you can ask questions, okay?
Thank you very much. I'm an IT professional, please, not a doctor. Okay. Nothing to do with the medical line. I'd like to ask Professor Abayomi, can we please access your presentation slides? Because there are quite a number of things that are there, very relevant to all of us, but I've searched through the brochure and I didn't see your slides. I hope we can have the privilege of having the slides, please. And you also mentioned about the Drug Management Agency and quite a few other things that the Lagos State government are making initiatives to do. How can we access information on these agencies? My interest there is in IT, is in big data. As you mentioned, data is everything. And I'd please like to access information about those initiatives. And I also want to mention that you mentioned having a University of Medicine whereby you will produce 1,000 doctors and so many others. And I'm just wondering that there will be many candidates that may opt for medicine, but they may not make the mark. I hope that there will be a way of counseling and still bringing them into the net to be able to do other courses within the medical profession. You might want to drop them from, they apply for medicine and drop them to something else. I just hope, this is like a suggestion, I just hope that there will be a plan to still keep them in the net and keep them in the medical field and still fulfill them. Thank you.
So thank you very much for that question. Yeah, sure, of course, the slides are accessible. We'll make it available to everybody. The second question was on big data and IT. So what we're doing is preparing. What happens at the moment is, if you imagine that all these tables are general hospitals, and there are about 30 general hospitals and about 70 big primary healthcare facilities in Lagos. Each of them is going digital, and each of them is storing their data inside their facility. So that's really only useful to you as a form of record keeping. It is of no value to me or to anybody else. So the idea now is to connect all these hospitals together and create an opportunity for the data that follows the patient. So when the patient engages for care, they either come in to see a family physician who then refers them to a specialist. From there they go to the laboratory or to the radiology service. They come back, then they go to the pharmacy, then they come back. And so there's a record of that patient's experience inside the facility. And then the patient may get referred because there isn't enough expertise in that facility to deal with whatever the diagnosis is. So the patient continuity moves to another facility. Now what we need to do is we need to capture that trail, and we need to be able to facilitate access to that information at the hospital, but anywhere else that that patient visits. Now, if all the data in all the hospitals are being collated into a central data archive, then we're now putting together a very rich database of health-seeking behavior in Lagos, which is not only important for the caregivers, but it's important for the policymakers, it's important for research, it's important for the pharmaceutical industry, it's important that we see the trends that are happening. We can use that information because maybe some of the health-seeking behavior is anomalous. And we can now define public awareness campaigns that will help to correct ways in which our citizens are seeking health and also bring it in line with international best practices. So that's around the data. So the SHIP is basically to create a centralized database, an opportunity to move information around seamlessly, to mine the data, to do advanced data analytics, to create trends, for the patient information to follow the patient as is required in the patient's journey through both public, private, or different tiers of healthcare delivery. Your third question was around the new University of Medicine and Health Sciences. So every year, there's a standard of excellence that's required for admission into medical school or law or architecture. So generally, we're looking for the high grades for medicine. So we get almost 4,000 applicants a year that are above the threshold for academic admission to medicine. And we only take 100. So there are 3,000 plus students that qualify to study medicine by our standard. Generally in the grades, in A levels we used to call it B's and A's. There are certain criteria now. So if you make that cutoff, but there is no space for you to study medicine, you find students going to the Ukraine, going to the Caribbean, going to India, going to everywhere, because they want to be doctors, they want to be dentists, they want to be pharmacists, they want to be nurses. And we don't have enough space for them in our training institutions. So it's not a matter of dropping the standard. The standard is there. If we're only admitting 1,000, we still have 2,000 students that could be studying medicine, but we don't have space for them. So we're nowhere near an argument that there's a decline in standard of admission. If we could admit all 4,000, maybe after we get to 1,000, we can think of increasing it to 2,000. And just like in London, London has almost 12 medical schools, each of them graduating 200 doctors a year. That's 2,400 medically qualified doctors produced in London every year. And what they do is they train their students in both the parents' medical school and all the general hospitals and family medicine practitioners in the jurisdiction of that medical school. So I studied in London. I know that system very well. I would come home to my parent university maybe for 3 months in the year. The remaining 9 months, I was out in the field, in general hospitals, across the drainage area of that teaching hospital. So we're not sweating our assets in Nigeria. Nigeria has millions of patients. And like a mechanic that is learning to be a qualified mechanic, you go and spend time with your mentor, who you work for 3 or 4 years. fixing the gearbox, fixing the carburetor, fixing the brake, whatever. You learn by doing. You don't learn by sitting in front of a lecture and them telling you that this is antibiotic. You need to learn what is antimicrobial resistance in practice. How do you do it? It's not a theory. Medicine is not a theory. It's a practical apprenticeship. And what you need for apprentices is patience. And what we have in Lagos is 30 million population with millions of patients. So what are we talking about? We should not be short of doctors in this state. I can't speak for Nigeria, I'm speaking for Lagos. There is no reason why we should have a shortage of medically qualified professionals because we have what it takes to train them. And that's what we are going to do in Lagos. Thanks.
Thank you, thank you, thank you, thank you. Thank you. Oh, there's a youth couple there.
Thank you, Honorable Commissioner. And the Honorable Commissioner may not remember teaching some of us in the hematology daycare unit in UCH. Now, this brings me to my question, sir. I know that the easier part of the equation is to get those more students into medical school, but the harder part is the specialists. What are you going to do? Because it also doesn't lie purely within your powers. National Postgraduate is West African College. How are you going to get the specialists? Because the specialists are living, and they are living in droves too. Secondly, I am beginning to be afraid that maybe these medical degrees that we will soon be giving out will no longer be attractive to countries abroad if we're not producing quality doctors. The reason they're after our doctors is because they are sure of the quality. And I am worried about the quality of doctors that we're going to be mass producing. And I will be very grateful for you, sir, to address those issues. Thank you very much.
Thank you.
Okay, so thank you. I think I remember you. Your face is familiar. So you ask a very interesting question. So in the general hospitals that we have, the 30 general hospitals, who works there? It's full of specialists, but they are focused on service delivery, which is different from LASUT that is focused on teaching, research, and service delivery. So you might as well be in LASUT because you have a fellowship in obstetrics, you have a fellowship in pediatrics, in internal medicine, microbiology, whatever. You're just working in a general hospital and you're focused on service. But even then, we still accredit our general hospitals for housemanship, for certain programs in our postgraduate college. So it's not as if our specialists in our general hospitals are not accustomed to teaching. All we have to do is create a reorientation of our specialists, that they're not only going to be involved in primarily service delivery, but we're going to combine it now with service and training. And that is not an alien subject. It happens all over the world. We actually have more specialists in our general hospitals put together than we have at our tertiary academic center. So we're not short of specialists in our general hospital. Furthermore, we have 2,000 registered private facilities, medical facilities, registered with HEFAMA in Lagos. 2,600 to be precise. Some of them are big hospitals, full of specialists. And again, it's not a foreign concept for someone working in the private sector to be accredited to become a lecturer in a university as an honorary lecturer. And so when we look at the spectrum of specialists that we have in Lagos, we have in our analysis enough to go up to 1,000 students without compromising on quality. Furthermore, we are in the age of the digital technology, and many universities are using distance education. So for the first 2 or 3 years of medical school, a lot of it is didactic teaching before you have to go into your medical hospitals for your practical training. So with the 8,000 medical specialists in America, an equivalent number in the United Kingdom and Europe and all over the world, we have enough Nigerian diasporan specialists with academic backgrounds that we can recruit. And that's why the ship is so important, because we're building the ship not only to move data around, but to be a platform on which we can put any app that is necessary for us to advance healthcare delivery in Lagos. And one of those apps will be the training and academic app that will allow you to be in New York, in Chicago, in London, give your lectures to medical students, even do practicals over digital platforms. Now you can carry out a laboratory assay digitally. You can even, those of you that are medically qualified, you have digital cadavers that you can dissect digitally. You have robotics. So the medical field, coupled with the technological advancement, is really taking us to another place, especially with AI and deep learning now, that you can use modern technology. And when we were debating about the size of the new campus, they were saying, oh, you need 100 acres, 100 hectares of land. And people were saying 100 hectares. A modern university now is much smaller because digital technology is taking over. So you don't need huge campuses anymore. Just like we used to use big cars and big laboratory equipment, now you can do the same tests on little cassettes. So size is not what you need, it's technology. And technology can help us to achieve even higher standards of education if we adopt it and if we use it very well. So when we add the number of specialists we have in our general hospitals, to the number of specialists we have in our private hospitals, to the number of diasporians that exist all over the world that want to contribute to Lagos State's health sector development, we have more than enough. And the quality and the standard will actually be higher, especially if we partner with the private sector. Thank you.
Thank you very much, Commissioner. Is there any other question? Okay.
Good afternoon, House. My own is no question per se. Mine is appeal and request. May I seize this opportunity to congratulate Dr. Olupowale and celebrate you for this laudable and successful lecture. You have left your fruit on the sand of time, and I assure you that your name will be written in the book of life. A round of applause for him, please. Thank you very much. My appeal goes to the Commissioner, Lagos State Commissioner for Health, Professor Akin Abayomi. I'm not a medical person. I'm an educationist of a lower or running private primary university high schools, not even university. So pardon me for my question. And I put to you, sir, a request. This program, this is the third time I'm attending this program. And this little program we're looking about has helped so many universities. Two of the last ones were students from University of Abuja, Lagos, Ibadan, and all other universities. And after the lecture, all were brought here, went everywhere, and helped in eradicating diseases, even in hospitals and private hospitals. So we should not take this lecture for granted. God has really helped so many people, including my family, in this particular lecture. I thank you very much, Dr. Ubuwali. Then Lagos State, Mr. Commissioner, sir, is the heartbeat of Nigeria. And the last election, why people voted for the President Bola Tinubu, was that they said, we want him to replicate what he did in Lagos State to other states. And mostly that's why we won the election. So we always believe that the commissioner of Lagos State is the commissioner of all commissioners of Nigeria. A round of applause for him. Now my appeal. This is where I'm going to. I came in late because I was held up at Maryland Junction. So maybe Dr. Ubuwali has explained why. What I always go to when I get to occasion like this is to read the reason why we are here and for what benefit. I always read the opening remarks of the CEO or the president or the chairman or whoever. I'm going through the opening remark. I saw, maybe you have explained before I came in. It is with a great sense of satisfaction that I arrived for the final edition of our initiative event in Lagos, and it dampened my spirit. Final edition came. When Mr. Commissioner is here, he has to tell us why he said that. And the Commissioner has to tell us how he's going to never allow it to happen. This is a thing that has turned so many lives, that has helped so many people, and has kept so many people living that they will have been dead by now. So probably Dr. Ubuwali will explain to me, and Professor will tell us how he's never going to allow it to happen. If it happens, it means that those who believe that Nigeria is dying gradually, they are really true. But that will not happen. Over to you, sir.
Well, that's a very loaded question. And I was going to get back to it. I started this program in my, base in America because I was the only infectious disease doctor in my town for about 12 years. And I just wanted to bring, some other specialists who could educate, the people in my community about infectious disease. I started about 17 years ago, and it grew, it really grew. But I thought charity always should begin at home. And I brought it to America, to Nigeria, about 4 years ago. The first edition went well. The second edition went, the third edition went well. But this one has not been easy, I can tell you, okay? It's not easy, to combine what I'm doing, where I am. I'm not on the ground, I depend on people to do things for me here, okay? I'll put it closer to the one in America, sister. I'll put it closer to the one in America because they say it's always good to lead the stage when the ovation is loudest. Never leave when the noise is going down, okay? The reason why I'm stopping the one in America and in Nigeria is because of the logistics. Look at this room. My vision was to have this room filled with doctors. I'm not saying those of you that are here are small, no. But for doctors to register, to come and learn from different parts of Nigeria, from different universities, okay? It's very difficult. I mean, 3-4 days ago, I only had 15 people registered for this program. 15. And I prepared for 250 people. Okay? Various problems. And I just thought that, my dream about, stimulating people's interest, my specialty or infectious, is to know about it, because the professor said something about all fevers got malaria and typhoid. And that was my motto, that I wanted to make sure that people know about my specialty. And I think I've done it. Sister, I think I've accomplished that, okay? And I don't think, I need to labor myself to do it. You see, most of the people that are here today, most of the people, the youth corporals, the medical students, it's my friends in America that paid for all of them to come. My classmates are there. GCISM, please stand up, to be recognized. These are my classmates. We entered government college Ibadan, 1972. None of them, they are not doctors. None of them is a doctor. None of them. I have microbiologists there. But I'm just saying that, they rally around me, say, Falarin is doing something, we don't want him to put to shame. They put money together and they came. The good Lord will bless you, and whatever it is, we're going to be together forever. In the mighty name of Jesus, okay? My medical school classmates too. I was at Luth, I was there 78 to 83, okay? We have so many people in Lagos. In my set, only 2 people are here today. Who's there? Who's there? Oh, Bola. Bola is the professor of dermatology, University of Ibadan. Toyi. Professor Kupi. Yes? Who else again? Oh, Shola. Yeah, Shola, I'm so sorry. But I'm just saying that, there are so many of us that are here. You put it on the forum, nobody will respond to it. I'm not trying to advertise myself. I don't need any recognition. I don't. All I want is just to make sure that people know about infectious disease, to stimulate. I tried to start a telemedicine program at University of at my medical school. Yeah, it failed. So I've tried, and I think I've tried. I'm getting old now. I'm going to be 65 in January. I'm an old man, and I think I need to use my energy. Yes, to do some other things that are more productive. Okay, I'm satisfied with what I've done, and I'm happy with what I've done. I've made my mark, and I pray that somebody else will take over from here. Thank you.
Yes, my question goes to the Honorable Commissioner, Professor Abayomi. Yes, I want to appreciate all the effort you've put in place so far in our health system in Lagos. So you've talked about building a capacity building and indigenous research in Lagos, which you've laid more emphasis on lining up of group of researchers from grassroots and youths for this journey. So my question goes to those, what are the strategies to bring those in private sectors, those in academics on board as well, so that we can work in hand together to achieve this feat at the end of the day? Because I believe with everybody on board, we should be able to get to the desired destinations. So that is my own question. Thank you.
Okay, thank you. So at the end of, during COVID, for example, we put a research team together that eventually was the size of about 40 or 50. But it was led by academics from LASUTH and LUTH, because that's what they do. So it needs to be led by seasoned academics, but the composition was everybody. There were even traditional medicine practitioners, there were private sector, there was industry, everybody was involved. So it's not a matter of just focusing on our teaching hospitals, no, but you do need a research team that's led by seasoned academics and then supported by a spectrum of practitioners, not just in health, but in our research, we're looking at all kinds of things. We're looking at logistics, we're looking at social behavior, we're looking at everything, including mathematics and modeling and those kinds of things, because during the pandemic, we spent a lot of time modeling. So it's not only about medicine, it's about everything that you need to address a problem, and the research during shocks is different from research outside of shocks. So research outside of shocks is happening all the time, but research during a shock is a different ball game, and you spend almost 70% of your time in a shock research environment looking at logistics. Logistics is the beginning and end of a response. The actual medical countermeasure is a small component of a outbreak response strategy. And there you need a whole spectrum of people who are not medically qualified, who will support you in your biological shock response. But having said that, one of the biggest problems we have in Africa is that our research is funded externally by international donor agencies like NIH and Wellcome Trust and JICA and everybody else except African governments. And you know that what they say, he who pays the piper calls the tune. And people are coming to fund research not because they like you. They're coming to fund research because they want something from you. They want to build their own bioeconomy with intellectual property that they derive from you. And so we become simple collectors of data, collectors of sample, and we export it, just like we export our cocoa and our crude oil. And then we re-import sophisticated chocolate and sophisticated refined products. And we've been doing that for decades in Africa. We've become sample collectors and not innovators, with research and development contributing to the bioeconomy of the environment. So what needs to happen is that our governments across the continent need to understand that they need to fund indigenous research for indigenous researchers, for indigenous solutions to drive indigenous innovation pipelines, which results in research and D. What does D stand for? What does D stand for? Development. Without research, there is no development. So we can continue to rely on external funding. It's doing research and development for everybody else except us. So research, very important. If you're in private sector, public sector, academia, it doesn't matter. We have to do local research, and the governor of Lagos State is beginning to fund local research both in medicine and science and technology. And hopefully that trend will continue so that we have locally funded indigenous researchers doing work on things that are important to us without any ulterior motives, simply because we want to promote our own cadre of researchers in Lagos State and Nigeria.
Thank you very much. Anybody else? Any other questions?
Okay, good afternoon, everyone. My name is Lovett Idowu Simon. I'm an NYC doctor with Orile Agege. Please, thank you very much, sir. My question goes to the Commissioner of Health. I'm very impressed that Lagos State is doing a whole lot for its citizens, but I'm concerned mostly about this water purification system. I understand that most homes get to dig boreholes. So how does the government really come in making sure that they have good water? Thank you.
Okay, so I'm not the Commissioner for Environment or Water, but I am a member of cabinet, so I know what's going on. So you have, in a city like Lagos, you have about 4 sources of water. You have groundwater, you have river water, you have lagoon or seawater, and you have rain catchment. So what we've been relying on predominantly around the period of independence was we built some rather sophisticated freshwater treatment plants. So they drain water from the big rivers, especially Ogun River, and you treat it, and you purify it, and then you reticulate it into the city. But because Lagos has been growing so fast, it has outstripped its the supply from this source. And so citizens have resorted to groundwater. And there are two sources of groundwater. There is well water and there is deep borehole water. It depends which one you access, but the well water is a superficial aquifer, and a borehole goes down to the deep aquifers. But you can go, there are many aquifers, so you can go as deep as you want. The deeper you go, the cleaner the water is. The more inland you go, the cleaner the water is. So on the mainland, you have relatively good water from your boreholes. But if you go to the island, because of the geological nature of coastal terrains, there's a lot of sediment and iron and heavy metals inside the deep water aquifers. And on top of that, you have anthropological activity on the surface that percolates down into the waterbed, the superficial and the deep aquifers. So there's a challenge there, and the geologists tell us that the more you tap into your deep aquifers, you're creating a vacuum under the earth, 200, 300 meters down, and your land starts to sink. All right? So if you look at some of the projections, Lagos is sinking, like many other cities around the world, because of excess utilization of groundwater. So the government recognizes this, and we're spending a lot of money rehabilitating and building new water treatment plants, huge ones. If you ever fly into Lagos, I just look out of the window as you approach Lagos, you will see huge water treatment plants on the outskirts of Lagos that are bringing in water from Ogun River into these big tanks where they are filtered, they are treated, and then they're reticulated. But because Lagos is growing so quickly, it's outstripping the ability, but we're trying to keep up as much as possible. The Commissioner for Environment is working tirelessly with the General Manager of the Water Corporation to try and return Lagos to reticulated water from our big rivers that flow into Lagos. There are about 8 rivers that flow into Lagos. And so we're trying to get water from those sources, treat them, and deliver them to the citizens while we retard or slow down access to borehole water. Because ideally, we don't want too many boreholes taking water out of our deep aquifer. We prefer fresh water coming in from our rivers that are flowing into Lagos. But with the amount of deforestation going on in Nigeria generally, these big rivers are getting silted because you cut down your forest, you get runoff of surface soil into your rivers, and so your rivers are getting a little bit shallow, which means they're not carrying enough water at that level, and so when it rains heavily, that water is transmitted to Lagos, which is why Lagos is always seemingly flood prone. But we need to address all those issues as national issues around climate, environment, and water access.
Thank you very much, Commissioner. Well, no more questions. No more questions for Commissioner. No more questions. The event is over. It's declared over. You've done very well. Please. Thank you very much. Well, I thank God that it's not a lot of people that have the opportunity of starting something and putting an end to it. You did not come here to celebrate me lying down and not being able to respond to you. I'm alive. And I'm still going to do greater things. So this is not the end, you know. If you have projects that you want me to do, I'm always very interested in making sure people succeed. Okay? So this is not the end of Fola Olubuwale's activity. I will always participate. I will always help my medical school. I will always help my high school. So this is not the end. I thank you very much for coming. I know you all came from far and wide. I just want to bless all of that came, because it's not everybody that came, but you decided to come. I appreciate that, you know, and I hope that whatever you guys lay your hands on will prosper, and the good God will bless all of you. In the mighty name of Jesus. Thank you, 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 thank you.